कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
I would like to thank IMA Sangli for giving me this opportunity. So let's start with today's first topic. So now we will be discussing about role and benefits of a class of drug, that is SGLT2 inhibitor, Canagliflozin being an SGLT2 inhibitor in diabetes. Now, what do we wish in diabetes? We want a medication which can hit the eye of the bird. So we want something which does well for our patients with diabetes. Now, how do we say a drug will be good in diabetes? So basically, we need to look at the type 2 diabetes treatment goals. So we want a medication which has potent and durable glycemic control and which avoids collateral damage. The medication should not have hypoglycemia. It should not cause weight gain. So these are two things which we wish. Now, what is this class of drug called as the SGLT2 inhibitor? What we are discussing today, that is Canagliflozin. Interestingly, Canagliflozin comes from this class which was originally described in the barks of apple trees. Now, in this slide here, you see a red apple tree, but actually this was originally isolated from bark of green apple trees. The medicine is called florizine. It has different medicines according to either the O-glucoside or the C-glucoside chain. Now, what is the history of SGLT2 inhibitors? Now, since ancient times, people knew that there is some element in the bark of apple tree which can reduce sugars. But in the recent times, it was only in the year 1835 that French chemists first isolated florizine from the bark of apple trees. Interestingly, French people are known to give a lot of medications to present day armamentarium. The metformin, what we most commonly use, was also has originated by the French chemists. Now, the journey of SGLT2 inhibitors began in 1835, but until 1886, there was not much development. In 1886, German scientist Joseph Mering demonstrated that fluorescein can cause glucoseuria. People were then worried whether this drug which causes glucoseuria will actually help. Then came the description of people with familial renal glucoseuria, and it was proven beyond doubt that if we excrete glucose in our urine in large amounts with this drug, it would actually be safe. And then came the year 2000 when the first patent application for fluorescein was applied. So the most commonly used SGLT2 inhibitors presently happen to be dapagliflozin, canagliflozin, and empagliflozin. Now, how does this class of drug work? Now, let's look at the role of kidney in glucose homeostasis. In diabetes, we have multiple medications, but this class of drug, SGLT2 inhibitor, is very unique because it uses the kidney to lower our blood sugars. Now, how does it do it? Now, we all know that kidney contributes to glucose production. 20% of the endogenous glucose production, gluconeogenesis, happens in the kidneys. There is glucose reabsorption in the kidneys from the SGLT2 receptors and SGLT1 receptors. Now, the brain has an obligate requirement for glucose. When we are sleeping at night, we are fasting. During our fasting, the obligate requirement of glucose to the brain is provided by two organs. The first being liver, which contributes to 85% of our gluconeogenesis at night. And the second being kidney, which also contributes by around 52%. So that is a significant number. Now, what happens in diabetics is that there is a maladaptation. Normally, a diabetic person who has high blood sugars should excrete more of glucose through the kidneys. But unfortunately, in a diabetic person, there is a maladaptation which leads to excessive contribution to the blood glucose from the kidneys. So you see, in non-diabetics, it is 15% which is contributed from the kidney, but in diabetics, it is 25%. So there is basically a basic maladaptation in type 2 diabetes with reference to the kidneys handling of glucose. Now, how significant is this volume of glucose that is handled by the kidneys? So just for an estimate, if a person has a HbA1c of 8%, more than 250 grams of glucose is reabsorbed through the kidney in 24 hours. That is really a significant amount. And if you have a drug which blocks this reabsorption, definitely it will help. So that is the whole basic pathophysiology, how this class of drug, SGLT2 inhibitors, act. Now, this is the renal glucose handling. We know that the renal threshold for glucose is 180. Now, let's say a non-diabetic person has a very heavy meal, has a lot of carbohydrates in the meal, and the blood sugars start going high. So the physiology takes care that the blood sugars don't cross a threshold of 180. Once the sugars tend to go above 180, the kidney is supposed to excrete all the excess sugar. Now, in diabetics, unfortunately, there is a maladaptation. So, non-diabetic person excretes glucose once it reaches 180, but a diabetic person fails to do so. The threshold has gone high. Here you can see in this slide, it is about 220. Now, what this class of drug does is, this is normal physiology. This is the pathology, that is type 2 diabetes. And this class of drug, SGLT2 inhibitor, that is all three, the dapagliflozin, canagliflozin, and empagliflozin, they lower the renal threshold. They lower it significantly. So you see in physiology, it is 180, but the drugs may lower it to even up to 40. So what happens is that the kidneys excrete all the excess glucose. That is a welcome change for diabetic. the person will be excreting the glucose through urine and it helps. So this is a class of drug, unfortunately, which was not touched upon for decades. The past 1.5 decade has been the decade for SGLT2 inhibitors. This class of drug is now extensively used across globe with multiple benefits. In fact, you can see here that tissue studies have shown that there is upregulation of SGLT2 receptors in a diabetic kidney. So if you give a drug which blocks this receptor, you excrete glucose through urine and that lowers blood sugar. That in addition has multiple benefits. So the first 3 drugs which have been described in this class of drugs happen to be dapagliflozin, canagliflozin and empagliflozin, a wonderful class of drug, multiple benefits in diabetics. So this is a pictorial cartoon. So this is a nephron. You see the filtered glucose load, 180 grams per day. It goes through the proximal tubule. It goes through the distal tubule. The SGLT2 receptors contribute to 90% of reabsorption. Now, if you give a drug which blocks this SGLT2 receptor, so what will happen is that the 90% absorption will get blocked and we excrete the glucose out. Now, why this class of drug has shown multiple benefits? Now, till date, we have been using multiple medications in diabetes, namely sulfonylureas, insulin, thiazolinidions, and so on. Now, classes of drug like the sulfonylureas, namely the glibenclamide, glimepiride, gliclazide, these are good drugs to lower blood sugar. But unfortunately, there is something called the KGA1C paradox. So if you control the blood sugars, but unfortunately, if there is weight gain, that negates the beneficial effects of blood sugar control over the long run. So we want medications which lower HbA1c, at the same time, they lower the body weight. That will lead to better cardiovascular outcomes in a diabetic patient in the long run. The collateral damage of weight gain during type 2 diabetes control has been studied in multiple studies, be it the Accord, the Framingham Heart Study, the Inter-Heart Study. All have shown that weight gain associated with 22% increase in overall mortality, 2.25 kg increase associated with 20% risk in severe risk factors in men, and a significant 37% increased risk in women. So what this means is that we should use medications for our type 2 diabetic patients which do not cause weight gain. And if they cause weight loss, that is always a welcome idea. The collateral damage of weight gain during type 2 diabetes. This is a wonderful meta-analysis. You see that multiple trials, right from Savertime to Proactive to the UKPDS, all have shown this hazardous effects of weight gain when we manage type 2 diabetes. So this is a balancing act. We need to treat our patients, balance the benefits of HbA1c reduction, and do not cause weight gain, and try to cause weight loss with associate along with HbA1c reduction. Now, in the year 1900 and after the discovery of multiple medications for diabetes, the year 2009 was very different. There was something which we called the rosiglitazone fiasco. So a class of drug, thiazolinidione, rosiglitazone, showed that there is some cardiovascular risk, although it lowers blood sugars. So since then, we have been waiting for drugs which not only reduce the blood sugar, but also protect the heart. And if they protect the heart and give additional benefit, that should always be the best choice. And mind you, SGLT2 inhibitor is a class of drug which does exactly the same. It is not only CV safe, but also offers CV protection. Now, let's look at what different classes of drugs do to the CV risk. Now, basically in a type 2 diabetic patient, what leads to morbidity and mortality is the cardiovascular risk. So you look at a holistic approach of lowering the blood sugars along with lowering the blood pressure and lowering the lipid levels. Now, since the statins came, we knew that in the pre-statin era, there was a lot of cardiovascular morbidity and mortality. And since statins came, we know that statins reduce morbidity and mortality. you can see that number needed to treat was 30. Then came in the era of ACE inhibitors and ARBs, first shown by the trials for Ramipril and subsequently trials for ARBs, that the number needed to treat to show cardiovascular benefit is 56. And today, when all our patients are already on a statin and ACE inhibitor or a ARB, you can see significant number needed to treat. You just need to treat 39 patients in the background of statin therapy as well as ACE inhibitor and ARB use to reduce the cardiovascular morbidity and mortality. So definitely selecting a class of drug SGLT2 inhibitor, that is Canagliflozin or Dapagliflozin or Empagliflozin, has dramatic benefits in improving our patients' longevity. So these are the SGLT2 inhibitors. Now, over the past 1 decade, we have had number of trials. It all began with the trial for Empagliflozin. It was called the EMPA-REX study. This study changed the whole paradigm in the management of type 2 diabetes. The study was done to see whether this Empagliflozin is safe in terms of cardiovascular outcomes. But the whole world was stunned to see that the result showed that Empagliflozin is beneficial for cardiovascular outcomes. It is not only safe, but it reduces cardiovascular mortality. Then came in the studies for Canagliflozin, the CANVAS study, Dapagliflozin, DECLARE-TIMI. All these 3 studies have shown that SGLT2 inhibitors have cardiovascular benefits. They have shown consistent benefits in terms of reduction in hospitalization for heart failure. Then came a study called the CREDENCE for Canagliflozin. This, I believe, is another game changer. Till the CREDENCE was declared in 2019, till then we had only one class of drug, that is ACE inhibitors and ARBs, which could reduce the deterioration in the renal function. Now, we all know that unfortunately our type 2 diabetic patient has a decrease in eGFR as he progresses through his journey of type 2 diabetes. A class of drug, that is ACE inhibitors or ARBs, can reduce the decline in eGFR in a type 2 diabetic patient. Subsequently, number of trials were done for multiple agents to see whether any agent can decrease the deterioration in eGFR in a diabetic kidney disease, but none showed benefits. It was only until the study for Canagliflozin, that is the CREDENCE study, that the benefit in terms of diabetic kidney disease was seen. So here you have a drug which started showing benefit in terms of cardiac outcomes and also shows benefits in terms of renal outcomes. So it is not just about glycemic control. It is giving protection to the heart, to the kidney, improving patients' quality of life and decreasing mortality. So multiple benefits. Now, how this class of drug gives benefit to the kidney? Now, we all know that this is normal physiology. In diabetic nephropathy, stage 1 happens to be a stage of hyperfiltration. Now, you see here that because a diabetic patient has more of glucose in the renal tubules, there is increased sodium glucose reabsorption. This leads to decreased sodium delivery to the macula densa. That leads to afferent vasodilation. So the afferent arteriole has vasodilation. That leads to high glomerular pressures. That begins the deterioration in diabetic nephropathy. Now, if you have a class of drug, namely the SGLT2 inhibitors, what do? They block sodium glucose reabsorption in the proximal tubule. What that leads to is increased sodium delivery to the macula densa. That in turn leads to afferent vasoconstriction. This reduces the initial stage of diabetic nephropathy, that is glomerular hyperfiltration. So you tend to halt or reduce the progression of diabetic kidney disease at stage 1 itself. This benefit is not provided by other drugs. And this benefit is additive to the benefits provided by ACE inhibitors and ARBs. So this is a wonderful drug, should be initiated early provides long-term cardiovascular benefits as well as renal benefits. Now, does glucose-urea harm? Is another question that comes to our mind. You're giving a drug to a patient which will cause excessive glucose-urea. Now, for diabetes, life has come completely U-turn. We know that Madhumeha, diabetes, began by describing that there is glucose in urine. Now we have come to a drug which actually increases glucose in urine. Now, will it hurt? And the answer is no. Because you see that in patients with familial renal glucose-urea, in spite of large volumes of glucose being excreted through the urine, it causes no harm throughout their lifetime. Now, is SGLT2 inhibitor a glorified diuretic? We say that it causes diuresis, it causes glucose-urea, it lowers blood sugars, it gives benefit to the heart. So one may argue that it is similar to a diuretic, but in fact, it is much more better than a diuretic. It is not just a glorified diuretic, but it is much more. The benefits extend to that it causes uric acid excretion. So uric acid levels come down. And we know that decreasing uric acid levels is beneficial in multiple ways. There is natriuresis, there is benefit for blood pressure, there is decrease in plasma volume. All this has multiple benefits. So it is not just about blood glucose lowering, it is much more beyond that. You see natriuresis, you see uric acid levels going down, you see reduction in weight. All these are beneficial things. Now, we discussed about three important trials for Canagliflozin and SGLT2 inhibitors and the Credence trial. Now, in fact, other trials, the DAPA-CKD, which is also a trial in chronic kidney disease with dapagliflozin, SGLT2 inhibitor, has shown similar benefits. So probably this benefit extends to this class. So we should be using this class of drug more extensively for our patients. In addition, it gives benefits for multiple outcomes. Now, the basic difference between a loop diuretic and a SGLT2 inhibitor, you see is it there in this cartoon. This is a bad endothelium, a diabetic patient with high cardiovascular risk. What SGLT2 inhibitors do is a reduction of interstitial fluid. So there is a difference between intravascular volume reduction and reduction in interstitial volume. In a loop diuretic, when you give diuretics to a patient, there is a reduction in intravascular volume, but that does not happen that significantly in SGLT2 inhibitor. On the other hand, there is a reduction in interstitial volume. So see here beautifully the difference between the pathology and these two classes of drug and the benefit of SGLT2 inhibitor. SGLT2 inhibitors selectively reduce interstitial volume. This may limit the reflex neurohormonal stimulation that occurs to response in intravascular volume contraction with traditional diuretics. So a wonderful drug, Canagliflozin, SGLT2 inhibitor class, corrects a novel pathophysiologic defect, reduces HbA1c, complements action of other anti-diabetic drugs. So it can be given any other oral hypoglycemic agent as well as insulin. In a type 2 diabetic patient, there is reversal of glucotoxicity, no hypoglycemia, reduces blood pressure and promotes weight loss. But I have put a very rosy picture of Canagliflozin and SGLT2 inhibitors. But we always have to be pharmacovigillant. Side effects should be assessed, and patient education is extremely important to reduce the side effects associated with SGLT2 inhibitor. Because this causes glucose-urea, we should educate the patient of good genital hygiene so that the incidence of genital and urinary tract infection reduces. Adequate volume of volume depletion can occur, so we should make sure patient has adequate hydration and should be avoided in patients at high risk of acute kidney injury. So multiple benefits, but we have to be pharmacovigillant. Now, how does it benefit the heart? Now, this is very interesting. We saw how it benefits the kidney, but Canagliflozin benefits the heart through something called the Robin Hood effect. Now, we know that Robin Hood was famous for looting the rich and distributing the wealth to the poor. Interestingly, Canagliflozin and SGLT2 inhibitors do the same in the heart. So what they do is that they produce micromolar amounts of ketones, and the myocardium loves to have ketones. So that is thought to be one of the reasons why there is benefit in terms of cardiovascular outcomes. Now, if you put together all these studies and look at this forest plot, you see wonderful benefits for canagliflozin and SGLT2 inhibitor as a class in terms of time to CV death. Now, mind you, we are looking at a hard endpoint of CV death, and there too you see most of the plots are to the left of unity. And if you look at time to first hospitalization for heart failure, the whole forest plot is significant, positive. You see the hazard ratios significant, confidence intervals not crossing unity, and the p-value is significant. So definitely this class of drug has multiple benefits. Now canagliflozin has two strengths. It can either be given as 100 milligrams, can also be given as 300 milligrams. Canagliflozin 300 milligram has a wonderful additional advantage of superior weight loss in overweight and obese type 2 diabetics. So we have a choice of canagliflozin 300 as well. In fact, the efficacy of canagliflozin 300 milligrams is comparable or even superior to the results seen with liraglutide, an injectable GLP-1 receptor agonist, which is another drug used in type 2 diabetes who are overweight and obese. So, ladies and gentlemen, we have moved on. We are moving towards precision medicine. When you are treating a diabetic patient, it is not just about glycemic control. You want to reduce long-term cardiovascular morbidity, mortality. You want to extend the patient's life before the patient ultimately requires dialysis. So you want to choose drugs which provide protection to the organ, not just glycemic control. So we have been using metformin for a very long time. Metformin happens to be the standard first-line agent in diabetes. Old is gold. However, we may have to give up gold for diamonds. So I would say that SGLT2 inhibitor class of drug is a diamond in managing type 2 diabetes. The foundational drug therapy should be metformin with or without SGLT2 inhibitor for organ protection. And then you can use multiple other. So my last slide, this is the most recent event that has happened in diabetes. Just 2 days ago, 27th of August, 2021, the empagliflozin in heart failure with preserved ejection fraction. This study was published. This is just 2 days ago. And this has shown that this class of drug, SGLT2 inhibitor, when given to a patient, even with preserved ejection fraction, can improve cardiovascular outcomes. So I wait here. And this whole paradigm of SGLT2 inhibitor is like the famous elephant. And you see multiple people realizing that it has different parts. But basically at the backdrop is the SGLT2 inhibitor, which is showing benefits. I thank you all. And I hand over to the chairperson for the question and answer session. Thank you. So you're muted, sir. Please unmute yourself. So you're muted. Please unmute yourself.
Hello.
Yeah, thank you.
Yes, sir. You have to mute it. It is. Yes, sir.
Hello.
You have to mute it. It is this thing is unmuted, so you have to mute. The voice is coming.
My voice is coming, na?
Yeah.
So shall I go ahead with the introduction?
No, sir. I'm explaining. Still question answer
please,
session
please.
is there.
Okay.
Once it is over, I will let you know.
Please. Okay, then you want me to mute it. Okay.
Till that, it should be muted. Thanks, sir. So it was a very nicely explained lecture, and he has very specifically emphasized that how this novel drug is not only reducing HbA1c and getting glycemic control, but it also reducing heart and kidney complications, and ultimately leading to reduced morbidity and mortality in those patients. So thanks a lot for this. Now, one inquisitive mind, once our inquisitive mind always have some queries and doubts. So now the platform is open for questions from audience. However, as I said earlier, for smooth conduct of the session, I request you all that instead of asking directly, you type your questions in the chat box of the Zoom app. I will ask them on your behalf. So if there are any questions, please type in the chat box.
There was a question.
There is one question. What about pre-diabetics? Would SGLT2 inhibitors be first line of treatment in this category also?
So presently, SGLT2 inhibitors are indicated for patients with type 2 diabetes. But I would say the avenue will be expanding. There are a number of ongoing trials to see whether this class of drug helps in pre-diabetics as well. Presently, the use in pre-diabetics is an off-label use. But yes, probably in future, it will be an indication. Number of ongoing studies are showing benefits in obese individuals as well as in pre-diabetes. But presently, it would be off-label use.
Yes, thanks. Another question is, please tell about Remogliflozin. Does it protect kidney in type 2 diabetes mellitus?
Yeah. Now, Remogliflozin is also a SGLT2 inhibitor. The studies for benefits for renal outcomes, the first benefit was shown for Canagliflozin in the Credence study. Then came in the benefit which was shown for Dapagliflozin in the DAPA-CKD. Probably we'll have to wait for the Remogliflozin outcome study. Presently, Remogliflozin does not have a robust outcome study like Canagliflozin or Dapagliflozin. And so we cannot extrapolate the benefits to Remogliflozin.
So can SGLT2 receptors can first line treatment nowadays? This is another question.
Yes. So now the guidelines world over are still endorsing metformin as a first line of therapy. But as I said, old is gold, but diamonds are forever. So last year, the Cardiology Society of Europe has endorsed that in obese patients with high risk, we should consider SGLT2 inhibitor along with, or if possible, GLP-1 receptor agonist as a first-line therapy in obese diabetics. So why wait to introduce this drug when you see robust long-term benefits? However, there are not a lot of constraints which make guidelines not to change overnight. But yes, probably in future, along with metformin or even before metformin, we may be using SGLT2 inhibitor. But presently, the first line of therapy happens to be metformin. And then you add SGLT2 inhibitor depending on the patient profile.
So another question from Dr. More is, please suggest which SGLT2 inhibitors for best weight loss?
Yeah. So if you consider different SGLT2 inhibitors, Canagliflozin 300 milligram has the best evidence for weight loss compared to all other strengths of SGLT2 inhibitors. So as the answer to his question is Canagliflozin 300 milligrams would give the best choice for weight loss, simply because Canagliflozin has also affinity for SGLT1 receptor. Now SGLT1 receptor is present in the gut. So when we eat food, the carbohydrate absorption is also reduced. So in addition to affecting the kidney, Canagliflozin 300 milligrams at a higher dose has significant effect on the GI absorption of glucose as well. So that leads to significant weight loss.
Okay. Question is, there is any evidence of calcium loss?
Now, there was a concern with SGLT2 inhibitors that some studies showed that it increased the risk of osteoporotic fragility fractures initially. Especially when the Canvas study, which was a cardiovascular outcome study for Canagliflozin, came out, there were reports of patients experiencing more incidence of fractures compared to the placebo group. But the subsequent studies in even higher risk patients, for example, the Credence, which was a very high risk patient population with diabetic kidney disease, did not show a significant increase in osteoporotic fragility fractures. So probably we should be pharmacovigilant. We should use the drug cautiously in patients who are at high risk for osteoporotic fragility fractures. But as a class, we should not be worried, especially in young diabetics who do not have comorbidities. We should be giving them the benefit of this class of drug. And we'll have to be vigilant for elderly individuals.
Yeah. Someone has again unmuted the video, audio. Please mute it. That is the request. The voice is coming. Hello. Hello. Somebody should unmute it. Mute it. Okay. Next question. Are there any benefits in the diabetic retinopathy or osteoporosis in long-term use of this drug?
Yeah, very interesting question. Now, of late, there have been 4 studies which are showing that SGLT2 class of drug, SGLT2 inhibitors, can provide some benefits to the retina. We were concerned about the retinopathy outcomes when we were using the class of drug, the DPP4 inhibitors. There were some concerns. But because this class of drug causes sodium glucose cotransporter inhibition, some studies have shown benefits for retinopathy. Although those are very small studies, we'll have to wait for long-term studies to make a statement. But yes, it benefits the retina as well, as shown by studies, especially for empagliflozin.
Okay. The question is, can SGLT2 receptors use with insulin?
Yes. So SGLT2 inhibitor can be added to any other class of drug in a type 2 diabetic patient. But we should be sure that we are looking at a type 2 diabetic patient. If you have misdiagnosed your type 1 diabetic as a type 2 diabetic and you prescribe SGLT2 inhibitor, it would be inappropriate because the patient may land up in ketosis. Now, in fact, newer studies have also shown that if your type 1 diabetic patient is on insulin, regularly takes insulin, and you add SGLT2 inhibitor, it won't cause ketosis. But they should not discontinue their insulin. But for type 2 diabetics on insulin, glucose-urea helps in reducing glucotoxicity. It helps in reduce the weight gain that is associated with insulin therapy. It also reduces glycemic variability. So multiple benefits when added to patients who are on insulin as well.
Very nice. So, Anna, last question probably. How can we shift from metformin to SGLT2 inhibitors?
Yes. Now, metformin happens to be the standard of care. Any type 2 diabetic, we start with metformin. Now, a subset of patients on metformin will not tolerate metformin. We all experience this. They have GI intolerance. They complain of gastrointestinal symptoms. So these patients, we are supposed to stop metformin and shift to another class of drug, where SGLT2 inhibitor would be the obvious choice. Now, SGLT2 inhibitors, all the SGLT2 inhibitors can be started on the full dose. Now, let's say for Canagliflozin, there are 2 doses, 100 and 300. So you can start with 100 milligrams, and if required, you can shift to 300 milligrams. Similarly, for other SGLT2 inhibitors, also there are 2 strengths. Dapagliflozin comes as 5 milligrams and 10 milligrams, and empagliflozin comes as 10 milligrams and 25 milligrams. So you can start with one of the doses and then up-titrate to the second dose. So that is simple way of shifting from metformin to SGLT2 inhibitor.
Yeah. Technology is there. What Sanjay said is we are really a byproducts. I bring you greetings from this glittering city of Navi Mumbai. This is a place called Kharghar and Ulve, where I say, and the next international flight you may take will be from this city. Everybody has got 2 in his pocket, or sometimes 3. And this was the evolution of telephone from 1876 to today. Even though it is 2011, in 2021, a smartphone has replaced even a desktop, almost like a dunya meri mutti mein. Friends, I'm going to tell you the story of technology in medicine in 3 parts. First part is going to be the telemedicine. Then about basics of technology, what are the apps? What are the devices which improve your clinical practice? It is which are built in your mobile phone, which are the peripherals which can be connected wirelessly. And last part will be the future of medicine, like augmented adaptive intelligence, big data, cloud computing, data mining, electronic health records, 5G revolution, artificial, virtual, mixed immersive reality. My request is do not take any snapshots of my slides. All my slides are available on the web, and at the request, I will send you the whole presentation by the email. except for my personal photographs, you can use everything out of it. COVID-19 and technology has changed our world. Have we anytime heard words like Zoom, giga, mega, terabytes? Am I visible or audible? Can you see my slides? My connectivity is poor. WhatsApp mark, recycle bin. It was in home only. Viral hone was a fever. Mining was an industry, nothing to do with data. But with technology, you have to be ready to accept the future. The cyber health won't maybe see you in the clinic. Your digital twin needs an antivirus cleaning and vaccination. With your genome sequence analysis, these anesthesia combination may get a malignant hyperthermia. These kinds of reports are likely to come. Your biodata profile predicts a risk of convulsion in next 72 hours. So please increase the dose of anticonvulsant. My good friend, Dr. Satish Khadilkar's assistant, may send a WhatsApp message to his epilepsy patient. We must thank these two people. The first mobile phone was parallel to our batch, 1974. Martin Cooper and Samuel Hurst, they have really changed our lives. But as Sanjay said, I am a Stone Age physician. 1974 admission, X-ray and ECG were the only things which were available in Mirrors Medical College. And our condition was like this caveman, not to do with the wheel, which is a great invention of today's. So why to adopt technology in health? In India, medical care aspect is increasing, technology advancing fast, equal or more pace. But out of all aspects, healthcare is the least user of the technology. So let us pray that the next generation will be benefited or teach you. So if you've got any problem in your smartphone or computer, don't ask any person, ask your grandchildren, they will help you. And why do we need technology? It is quick. Data sorting can be done very well. Sharvil has got 15,000 patients of diabetes. And if he wants to sort out Canagliflozin patients, at one click, he will get all the 3,000 Canagliflozin patients in one Excel sheet. The pace is done faster. CT-all, polypharmacy area, it is a very good thing. Then ease of management, empowerment. Even my assistant can complete 1/3 of my case paper. It is systematic. You can learn at leisure. It is a good opportunity. And in the future, the whole world is going to be yours. I'm just going to tell you a cricket team of inventions. If you recall, Seminibilis was the person in 1888 he propagated hand washing, which we are propagating even in 2021 today. Louis Pasteur, Mendel, incubators, angioplasty, Barry Marshall, prion theory, traumatic brain injury, or even circadian rhythm till October 2017. Medical breakthroughs, they were initially ridiculed or rejected. And in the words of Barry Marshall, who invented H. pylori, he said that everyone was against me, but I knew I was right. I think this is going to same thing which is going to happen with technology. So let us go to the first part, that is telemedicine. I just changed what Neil Armstrong said. Telemedicine, one small step for IT, but is a giant step for healthcare. It provides healthcare where there is none and improves the healthcare where there is some. So it is always a very exemplary step up. And I'm not going to tell you anything out of these guidelines because these guidelines are available freely on the web. And on 25th of March 2020, there is a revolutionary step in healthcare in our country which happened. The telemedicine can be done in two ways, real time or synchronous, or store and forward asynchronous. What is synchronous? As simple as a telephone call or a robotic surgery, video conferencing equipment, or even an instrument which is attached. We have got a lot of ENT surgeons, but there can be a teleotoscope by a remote physician to see inside a patient's ear, and a telestethoscope allow the cardiologist to understand whether there is a S3 gallop or any murmur is there. Store and forward, that asynchronous consultations are done all by our friends radiologists or even by the ophthalmologist who can diagnose the diabetic retinopathy just by clicking at the retinal picture. What are the advantages of telemedicine? There is a resource utilization, early intervention, avoids unnecessary transportation. Very important in this. It's a community-based care. It saves your cost, improves documentation, and increases range of our care and education. My quality of patient care has increased tremendously once I started using technology in my practice And my retention rate is not only 100%, but I can say 200% because my every patient refers another patient because of all the things which I use in my clinic. Just for an example, my batchmates are aware of my horrible handwriting, but my patients are and the pharmacist also equally scared. If I give away 10 or 15 drug prescription like this, and if my prescription is available in the second format, then my patients are very, very easy and very comfortable in knowing whether I'm supposed to take it before meal, after meal, or whatever the precautions which are needed, and it can be done into any regional language of the country. So this is the biggest problem of non-reliability of prescription, non-eligibility of prescription can be solved by telemedicine. So these are the 7 Satya Pe Satta points: context, identification of RMP and patient, mode of communication, consent, type of consultation, patient evaluation, and patient management, advice to the caregiver. So I always start my teleconsultation with, thank you for contacting me. I am Dr. S.V. Kulkarni, consulting physician. Can I know your problems? Please tell me your name and date of birth. So I have done 2 things. You have identified yourself, you have identified the patient. Friends, what actually happens during a telemedicine program? This is not something like this, what I am showing in which happens in other countries. This is a telemedicine operating room, but very simple way. You have got an operating system, you have got a licensed medical software, and there is a back-to-end based data with mandatory tables, feeds if applicable, and you store the consultation. There are few barriers: low or small bandwidth, neither telephone lines nor electricity in rural areas. Satellite transmission can be problem, basic amenities, fear of the patient, literacy rate, but all these things are getting over day by day. Like driving school, there is no WhatsApp learning school. There is no Facebook training center. We learn it by ourselves. Even our sadhus and grandparents now use smartphone in an effective way. But there are certain side effects for the professionals. If you use too much of technology, you ultimately become patients of Dr. G.S. Kulkarni, right from neck pain to the heel pain. So please avoid using too much of technology. There is an app in your phone which tells that how much of your screen time. If it is less than 7 hours, you are healthy. If you have more than 7 hours of screen time, you are a pathological person to suffer from side effects. So there are certain situations which are very unique. Nobody knows who owns the data, whether the patient owns the data, whether the doctor owns the data, or the service agency owns the data. For surgeons, it is a bit problem because till today, we cannot transfer the touch from electronic way. So these are the different scales which can be attached. It is a Wi-Fi scale, otoscope, blood pressure monitor, stethoscope, blood glucose monitor, and digital thermometer. There is a concept called as a machine-to-machine talk. So these are the machines which can talk to the machine. Or sooner or later, you may come across kiosks like this at home, office, or you will have a telemedicine health spot or a health pod. So if you want to stay safe, stay home, avoid exposure, use telemedicine. These are a few simple tips for making effective video consultation. SMS or WhatsApp a doctor 10 minutes before starting the video. Exactly tell what are the problems, send all your previous prescription. Do mention your diseases like BP, diabetes, arthritis, asthma, or if you are taking any treatment. Many of our patients are fond of taking Ayurvedic powder treatments, which are actually steroids, and then they have everything which is out of control. In patients who have got allergies, if they have got any pets in the house or family history of similar complaints, you need to save and send your very important numbers. And it has been said that experienced senior doctor can diagnose almost 85 to 95% of the conditions which can problematic in today's age by video consultation. I recall my days in medicine 2 unit of Dr. S.V. Sotur, where just at listening of the complaints of the patient, he used to tell what is the cardiological diagnosis. So then it is really very easy for us because we can see the video of the patient. It is a balance of responsibility versus liability. COVID-19 pandemic has altered many practitioners which are providing care to patient. We need to continue providing diagnosis, digital tools, and convert law of obsolescence into an opportunity to help theory of utility and weigh your views as user on the either sides. So consider this as opportunity. If you are not practicing telemedicine, start practice telemedicine. You use app like a Doc On or One Glance, whichever is comfortable to you. And the learning curve is slightly on a higher side, but then after it is very easy. So last 2 slides of telemedicine, you have to have proper lighting, proper network, clothing that allows visibility, quiet place to speak. You can listen my wife and son talking on the background, but she's also doing the same teleconsultation for her patients. You need to dress professionally. Please make eye contact, take your time, and most important is speak slowly. Don't tell your staff that if the patient is vomiting, give him injection pain on. The sister may give injection Pavlon and there will be a big problem. So this misconceptions of look like, spell like, and sound like drugs can be definitely reduced if you have got telemedicine, teleconsultation, and digital health records. You can use some simple Indian Jugaad systems. These are the earphones which are wireless. This is something really fantastic. All doctors are going to be deaf within a few years. The ENT people are going to go, good day. But these are the earphones which use your conduction from the mastered process. So your ears are spared. You can put on a stethoscope in your ear. So friends, that was the first part of my presentation. And I'm now going to quickly rush through some of the equipments which are associated. And incidentally, what you are seeing here is called as the Aurora Borealis or Northern Lights. This is one of the wonderful natural phenomenon. Once in a lifetime, you must see it. What are the basics of technology and what are the basic apps? And this is what we can do for our medical professional. How to buy, use, and recommend an app. You see who has created it, what is the person, what is the CV, what is the center, location, how many people have criticized it, how many people have reviewed it, and how many people are for and against. And there are certain good apps. One, Dr. Satish Devpujari, he has done wonderful apps in the pediatric field. So these are simple 1-point apps: body mass index, body surface area, converters of unit, anatomy apps, medical calculators, risk score stratification like ASD score, then pain coma score. What are the essential bundled life apps? These are the integrated and various features of the simple app. They are called bundled, that they pack up the features of the others, and a physician's smartphone needs to be at least one. And this terminology, bundled app, goes to our group because in 2009 in Kolkata, APCon, when I had a first workshop on technology medicine, everybody was laughing at me, but they realized that this is the real future. This is an app you should always have, calculated by QXMD. It converts all your things and makes your job easy. There was a first question in the last chat box: how to handle dose of metformin by simply calculating eGFR. So these are the various formulas which come, and these are the big fives of mobile health. Medscape, up to date, 30,000 rupees a year, but it is a good tuition fee. Hippocrates, Omnio is from our friend Hiren Shah's brother, Sandeep Shah in USA. So you should have at least Medscape, or if you want to spend some money, please buy up to date. So these are other technical apps which are helpful for our clinical patients. Prognosis is one thing which you can download for your continuous medical applet. So there is a lab work. Suppose if you have got some complicated lab work to be done, then this is the app called as a biochemistry quick lab reference. It tells you about different blood tests. Suppose if you want to know something about amniotic fluid analysis, which is not done very rarely, or diabetes screening test for a Sharvil's patient comes and asks me whether I have got a IGT. So this is the quick lab reference. It can help you in things like arterial blood gases. And friends, we are really very happy that Dr. Devpujari's apps are as good as these international apps. You please do download. ECG, if you want to evaluate, you can get it done for the non-physicians. It is a very simple app. All that anemias need not, they are some Never. So this is a Menzer index calculator for patients to diagnose thalassemia. This is the app developed by one doctor or from Nanded. Now this is my real-time patient. A patient of malaria, gastritis, ISD, asthma, PVC, was on erythromycin, domperidone, amiodarone. He was P. falciparum positive, started IV kidney, and what was the final outcome? Nobody will guess it unless you use something called as a drug interaction calculator. And this was the thing. The patient had a very malignant arrhythmia that is called as a torsades des pointis. And what was the reason? A patient was cold pulseless patient. He had prolonged QT. He had torsade dysphonia, which never responded to drugs or DC conversion, and the final outcome was death. So if this, I would have used this drug interaction app. Give me a minute. Give me. This is an app which is used for drug interactions. This was my patient of antitubercular, was already on antitubercular drugs. Then when we added phenytoin, it gave me an interaction that you may have to increase the dose of phenytoin as the patient is likely to go. So these are helps us for evidence-based management of medicine, multi-based tools and procedures. This is called as a Micromedex, a drug interaction app, which is by Reuters, which is a very authentic agency in not to spread rumors and spreading the real and authentic facts only. This is one card which you always should have, like Sharvil's patient. If you have got like card like this, and if you tell the patient, doctor, that he is on SGLT2 inhibitors, the doctor will be in a position to know everything. Like Satish patient, you can have a card like called as the I in case of emergency. It will tell you about epilepsy or whatever the things are there. And most important thing is this app opens when your phone is locked also. And it even tells you if you are fallen down in somewhere in hypoglycemia or met an accident, it tells you the location on Google Maps. Google Map is one thing which is not being used properly by all your medical professionals. It has got a huge potential, especially at the time of emergency. You can promote exercise and compliance by so many different kind of apps called as the Runtastic, which is for running and fitness. Then this Fitbit is for all, fits into any arm, any budget, or even it can diagnose obstructive sleep apnea. This is one of my patients. You can see the apneic episodes he is having when his Fitbit he wore, and then the analysis of data with that. Yoga, Dhan, medication, Vipassana, all can be done with the help of apps. And this is one wonderful app which increases your creativity, called as a Brainscape. Social medias are everywhere. They are going to be there with all of us, and we are using it day in or out, sometimes hours together. But friends, it is a double-edged sword. You have to use very carefully, but at the same time, the reach is unlimited. For example, a diabetes education. You have got so many positive points of diabetes education when you are using a social media. We really don't know. This was the time in 2000 when people were talking on dining table. Now we are just looking at your telephones and the mobiles. That is called as the fabbing, but we should not overreach it also. You can create your creativity, write your blogs and experience. We have got one wonderful writer, Dr. Shilpa Aroskar, Dr. Bhavin writes very nice. Rajesh Deshpande is known to everybody. Shantanu Abhenkar from Y is a wonderful person. Milind Kulkarni from Talere, Sindhudurg, and Dr. Harish Shetty. The blogs are very nice. You must use technology for this, for patient education. The data management can be done very nicely. I just give you an example of electronic health record. But friends, my word of apps, whether it is a Paradise or Maze, don't get lost into the maze, but use it very effectively. Now I come to the third part of my presentation. What are the clinical equipments, whether built-in, peripherals, wired, wireless, and what is the word of electronic gadgets? Your phone has got a lot of hidden equipments. It can be an eye torch, eye stethoscope, a magnifier, pulse rate or SpO2 calculator. Then it can be a cell scope like scale lesions, remote science monitoring, built-in mirror, flasher emergency. This is very something very important for female doctors or female medical staff, and it can be turned into a protective equipment. So these are the apps which can convert your camera into a big flasher, almost like a searchlight. So please do use these kinds of apps. For the ENT surgeons, for the pediatricians, this is the CellScope Auto Remotoscope. It is takes tongue depressor, thermometer, as well as otoscope. This is a wireless otoscope, hardly costing 800 rupees. There are different kind of thermometers. The thermometers can even send the thermometer readings to a mother who is working in a big NGO or big electronic corporation. This pulse oximeter has got one more reading that is called as a perfusion index. We are all going to get replaced with these kind of scales. No touch thing. This is body composition analysis, a wireless data sharing shoulder, or these are the made in India stethoscopes. It costs around 10,000 rupees. But if 1 lakh doctors use it, the cost will come down to 2,000 rupees. I know these people, but they are blocked because we doctors don't use technology. There can be a signal coder or a talking BP apparatus. If somebody has got problem with his eyesight, then the BP will tell you that your blood pressure is 110/70 or 90/70, and that will give a big beep also. And this BP apparatus communicates with your glucometer too. There are smartphone compatible BP apparatuses, mean the smartphone is inflating the curve of the BP apparatus. Or there can be simple 10,000 rupees Omron BP apparatus, which is totally tubeless. And this BP apparatus called as a quadri-arm, that is a wireless BP apparatus. Not only that, it is a tracker on Google, and it checks your blood pressure all 24 hours. This is the next addition in my Amazon list tomorrow. This is a company called Withings. These are manufacturers, watches, scales, BP monitors, sleep monitoring, and you can see the pulse, or you can see the ECG, possible diagnosis of atrial fibrillation. These mattresses, they give you analysis of your sleep apnea, heart rate, and detecting snoring. And this is a 3-in-1. It is a BP apparatus, digital stethoscope, as well as if you put at these 2 points your 2 fingers, you will get a ECG rhythm on your monitor. So this is the heart sounds, this is the ECG, and this all can be communicated to your doctor at a click of a button. For the ophthalmologists, where they cannot reach to the diabetic patient, this eye examiner system costing $850, or there are cheaper Indian systems. This is the first instrument which was accepted by the US government, AliveCor Cardia Mobile. It is a 6-lead ECG, and these are types of patches of Holter, which can tell you all the analysis for 3 days, 7 days, or even for 1 day. This is very, very helpful in management post-COVID patients. These are the point of care ultrasound. Just because of law, we are not going to get it, but all my critical care friends will be very happy just putting up for the IVC dimension. If it is collapsed, then you give more fluids. If it is full, don't give any more fluids. Very simple diagnose. So a way to diagnose overperfusion. Diabetes monitoring has been done fantastic with the help of kind of glucometers, which are there are many new players. And this is a smart watch. Israelis are way ahead of us. This is a smart watch which not only tells glucose, but it is all combination of one into a Fitbit as an exercise tracker. This is CGMS. Many of people must be using it. This gives a graph, but the newer model gives even the amount of glucose which is present at that particular time. And this is the graph which tells how the person is shifting at breakfast, lunch, and dinner, and how you can adjust the dosages. A very simple equipment called as a hypoband. Hypoglycemia or a heart attack is a common symptom of cold sweat. So in clinical medicine, as a teacher, I will definitely like to tell you that there are only 3 to 4 conditions which are associated with very severe sweating. No doubt, hypoglycemia, MI, internal bleeding, as well as impending onset of septicemia when the body becomes very cold and constricts. If you got a hypoband, it sends your temperature result to all your caregivers. This is something very important and very simple thing which you can. This is another Israeli equipment. It has got 17 parameters And these are the different types of watches which are going to come into the next few years. This tells you direct a glucose value, the iPhone, the iWatch which is going to come. Apple's iWatch is going to come almost 80,000 rupees, but this PK vitality will be somewhere around 15,000 rupees. This is an example of man-to-man and man-to-machine talk. This is called as a Go Cap or insulin check. It talks to the glucometer and decides the next dose of. So in short, you can have a connected patient, and there are make-to-do kits like this available. You can have all this cricket team of all your parameters, and you can just go on changing the attachments, and you will have a wonderful remote monitoring of the patient in case of COVID or otherwise those people who don't want to go to the hospital. This is called as a body position sensor or a fault detector. Even our mobile has got it. If your elder people are very prone for faults, so that frailty and fault detection can be managed with this. This is what I'm going to tell you is a very new one. This is called as Avid Heart. It is a small dabba like this. And I'm not talking anything out of the box. If you can see my video, this Avid Heart is in my hand right now. It tells you 7 different parameters: ECG arrhythmia analysis, hypoxia detection, temperature monitor, and it connects with any device which you have got. And there are few more things like FitKit, which has got all these SpO2 sensor, ECG sensor, BP sensor, temperature, and blood glucose. And this is the best way of remotely managing a patient. So you have to go to the website and get all the things done. This is my friend's son-in-law. Unfortunately, he is leaving next month to Canada because he was not accepted by Indian people. This is called as the AST Sense, UTI AST Sense. Put one urine and it will tell you whether there is a UTI or not, and it will tell you on the drug sensitivity also. So friends, after these equipments connected and non-connected, the last 7 minutes, I'm going to tell you something about what lies in future. That is AI and advanced application of healthcare. Artificial intelligence should not be called as artificial because we all are very intelligent people. It is an augmented or add-on intelligence. Early detection of disease. Parkinsonism can be detected by your voice analysis or your handwriting analysis. Improved decision-making, treatment, end-of-life care, connected care, and better overall experience for the patient. You might have heard this name called as IBM Watson. It replicates humans' ability to answer questions. It accesses 90 servers with a combined data store of 200 million pages of information, which it progresses against 6 million logic rules. And it really helps to you. It is not a out of budget thing. It is not a rocket science. Even in Sangli, you can hire Watson for your clinical diagnosis, clinical management, and data analysis. And most important is Watson is a good student. It learns from your mistakes and how he can point out the teacher's mistake also, which we are never allowed to do when we were studying. And this is a very, very promising field of AI in technology. I know that there are a lot of doctors' children. They don't want to be doctors. For them, this AI in healthcare and the various instruments in healthcare is one of the very lucrative friends. They will earn 10 times in what you have earned when the last zenith of your career every month sitting at home. So this is something very fascinating. It is called as a digital or biological twinning. What do you mean by this? My patient is diabetic. He has got a Fitbit, he has got a CGMS, and he has got a food diary. And I have got a database of 50,000 Indian food. So I come to know for breakfast, if he eats poha, if he eats upma, if he eats paratha, or if he eats plain chapati, how the sugar is going to rise and how I am going to manage this. These kind of things are available at a range of 6,000 rupees to 80,000 rupees, where the patient is coached by a virtual coach for almost a period of 1 year. And a reversal of diabetes is a near possibility with the help of this digital and biological twinning and beyond. Incidentally, in the next APICON of that is the Association of Physicians of India 2022 conference, I am going to be deliver a presentation on digital twinning and precision medicine. Precision medicine is something like that. Sharvil can look at the genome and sequence of the patient and tell that you are the only person who will be responded only by pioglitazone and not by other drugs, or you will be only responsive to Canagliflozin. The future is three-dimensional. There is something called as haptics. Means you use your hand motions, your touch to see the skin. And you will have a cameras like this. This is with 5G. I think if Dr. Satish Khadilkar has joined, he will appreciate this person. Friends, after few years, the words like monoplegia, paraplegia, quadriplegia are out of medical profession. These are called as the exoskeletons. And this exoskeleton is connected with a brain mapping device. It looks very bulky, but it has come down now, a band like this. This boy can think that I want to go and have coffee. His limbs will move to the coffee machine and he will take the coffee. So this is called as a thought-oriented or thought process-based instrumentation. So the future of diabetes or any NCD management is going to be futuristic and digital. This is an example of augmented and virtual reality. After a few years, all the 350 attendants of this CME will, if they wear a kit like this, they will see that as if they are sitting in a big auditorium. So these are the big future things: virtual reality, advanced monitoring, lab on the chip-based or chip-based prescribing. My niece in Kolhapur, she practices telepathology, and the microscope image which we used to see for 2 inches, her screen is of 52 inches. So these are personalized medicine also is possible. Telemedicine, telepathology, these are the near futures. All our Holker's anatomy hall will be smellless because there will be a simulation of your body. There are patient simulators for examinations and procedures. There can be a reality, mixed immersive reality for education. If Dr. GSK wants to educate his junior to how to insert a screw in the spine, then he can even get the sense of feeling also with the help of different gadgets what he's wearing. So this is something for the geriatric people, which is helpful in physical tasks, communication. These are assistive robotics. This reduces the need of movement. Like Alexa, you can tell him that, Robo, I want a glass of water. The Robo will come with a glass of water or a glass of wine, whatever you want. So friends, the last few slides, SWOT analysis of anything which is come. We have seen the areas of Galen and the nomadic medicine. The strength, it is a great happening place. Weakness, it is the extreme to set up, rural to 7-star. Staff, non-MBBS to non-trade. What are the threats? Time and expertise are crucial. Seniors not always available nearby, and resistance to adoption of new things. Health issues of the user, but the opportunities are endless. Information at point of care equals to life. So what do you want to change for all of 350 people from tomorrow? You are going to see what are the technology uses, how to do it. You check the 5 A's: accessibility, availability, affordability, adaptability, and various apps. Start using simple apps, calculate EGFR, disease scores, add a smart peripheral to your dumb phone, and do not forget electronic health record or telemedicine. From tomorrow, you are going to be a modern crow and a smart crow. It has been said by Robert Browning that a man's search should exceed his grasp, and this is the technology which is going to tell you how a man's sense can go off. This is a fall detector, electronic monitor, and a holter also for the patient. But before we end our smart chapter, we should not forget our teachers. The opportunities are endless for the next generation. It is up to us how to take and use it. Don't get lost into the maze of apps or trapped in the cobweb of the internet. Aim at what we want. Respect your teacher and your experience. Clinician's role always prevails. Technology changes, advances are welcome, but human touch, rational thinking, clinical acumen, and empathy are always non-technical and always will. Combine wisely, keep learning. Thank you, our people, for our motherland, and customize accordingly. This is a book of Dr. R.D. Lele, which I have edited, and he one of the main person for me to go into technology. So I cannot forget my batch, of which half of there in the audience, my family and my teachers. So if you got any questions and any reviews, you can contact on these numbers. This presentation is available freely. So friendly, be optimistic, informed, empowered, futuristic, build a bridge of knowledge and technology. So this is the new normal of safe medical practice. Use telemedicine, use video consultation and technologies.
Also, it was a very tempting discussion about futures, haptics and artificial intelligence in the medical field. Always we say technology is associated with young people, but I am sure that, sir, you are probably one of the most techno-savvy doctor in state or even country, even being such a senior citizen, a senior physician. So hats off to you, sir. Thanks once again.
Abhijit, I was invited in Yale University, Middlesex Hospital, Yale University, and in Pennsylvania, Hershey Medical for grand rounds on technology in medicine. And for last 10 years, we are conducting workshops in APCON in a national conference. This is the only recurring activity which is coming everywhere.
So should I correct, sir? I
Yes.
said that you are the most techno-savvy doctor in state or probably country. I should add probably world.
No, thank you. We are too.
No, it is amazing. It's really amazing, and we all doctors at least should have 10% of it to survive in our field. Thanks again. Hats off to you, sir. Again.
Start e-medicine from tomorrow. Start a telemedicine and start using electronic health record. That's all.
Thanks, sir. Thanks. Really appreciate it. Thanks, sir. So now the platform is open for questions from audience. I request you all that instead of asking directly, you type your questions in the chat box of the Zoom app. I will ask them on your behalf.
Abhijit, I have put my email ID in the chat box. Those who want, or you can contact our president, madam. She has got this presentation. My only request is please delete the photographs, personal photographs which are there, and then you can use this presentation for anybody. I don't have any rights on that, and you are most welcome me to get involved with different kind of apps and equipments. I am evaluating many newer instruments which are to be managed by telemedicine as well as for the remote sense monitoring. And we Indian students are very much ahead of this. If you have got an engineering college or electronics college anywhere around it, you can involve these people and ask them to innovate certain things. That is not a rocket science. This is just some play of sensors. Play of sensors.
Thanks a lot.
Thank you.
Yeah. So some questions I will ask on behalf of them.
There is one question. It absolutely metformin after raised serum creatine level. For Makaran, I will suggest you use this QXY calculate the eGFR of the patient, and then decide the dose of metformin. And the polypharmacy, all the physicians who are there in the group, they should use the drug interaction app so as to see which are the drugs which are not compatible with each other. You can prevent deaths because long QT is one of the biggest problem when you use the certain drugs along with a simple tablet of Ondem, 8 milligrams sublingual, and if the patient is on 4 other drugs which prolong QT interval, can precipitate ventricular arrhythmias and ventricular tachycardias like torsionis pontis, which are not very easily correctable. Rahul Ravikant is there with me. He will definitely agree as one of the toughest arrhythmia to manage in ICU is torsades. And if it is a drug induced, then we have to just wait for the body to wash off the drug out of.
Yeah, thanks. One question is there, sir. Do you think that with this newest technology, the old golden way of physical examination will be obsolete?
No, not at all. Not at all. I forgot one slide which tells you that was what Dr. Soltour, Lele, and Dr. Thomas used to tell. See, the first thing is to listen to the patient. Yes. History gives you 85% of the diagnosis. We don't have history. We see the reports first. We treat the reports first. We should not do. If any patient insists me that I should see the reports first, I don't see the reports and I even refuse the patient also. And that is the quality because it changes your mindset. You may start treating a small pulmonary nodule as a carcinoid syndrome when the patient has got actually a old healed calcified lesion and a common cold. So don't insist for reports, don't insist for investigations, go clinically. Clinical medicine is the mother of everything. And not even, I will say 95% of the cases can be diagnosed by history and physical examination. And there is now concept called as assistive physical examination. Even if you got somebody in the house who can see, and if you can tell the doctor, that is what we are doing, and we are really very successful in that.
I'm talking about the cardiovascular benefits of the Canagliflozin in a type 2 diabetes mellitus. We all know that cardiovascular diseases and type 2 diabetes mellitus is moving at a very fast pace. There are so many researches happening in both the field of diabetes and the field of the cardiology. Both fields are moving with a faster pace, and there are new medications coming every day, and every month you will get some new medicines in this field of cardiology. So now this is the new drug armamentum, that is SGLT2 inhibitors. There are so many to come with. There is a dapagliflozin, there is a canagliflozin, and now this is the drug canagliflozin, which is on a horizon for a treatment of a type 2 diabetes mellitus, as well as the treatment of the cardiovascular diseases. So let's see what exactly the SGLT2 inhibitors does and how it helps. When you talk about the SGLT2 inhibitors, these are the drugs which actually affects various mechanisms in the body. They affect on a heart, which reduces the oxygen carrying capacity. They increases the oxygen delivery. They decreases the left ventricular mass. If it also works on a bone marrow by increasing the erythrogenesis, so it increases the RBC mass and increases the oxygen carrying capacity. It also acts on a kidney by increasing the afferent arterial vasoconstriction and decreasing the renal blood flow. And this SGLT2 inhibitors also acts on renal tubular networks and with the brain neuroprotection. So the various idea of acting this drug, mainly we should understand that what it does is it decreases the inflammation, be it the inflammation in the bone marrow, be it the inflammation in the heart, be it in the brain or the kidney. It causes the vasodilatation, it causes the increased renal flow, it decreases the oxygen, it increases the oxygen carrying capacity, and this is the way it helps at the microvascular level. So all the potential direct myocardial effects of SGLT2 are cytokinin effects, that they affects the mitochondria, it affects the DNA at the myocardial cell function, and then it works by decreasing the inflammation. I won't go into the details because it will go and confusing you. We need to just understand that what it does is it decreases the inflammation, so that it increases or vasodilates the afferent arterioles, it decreases the preload of the heart, it decreases the afterload of the heart, and increases the heart pumping capacity by not increasing the oxygen, heart oxygen requirement or the cardiac oxygen requirement. This is what we need to understand when we talk about the SGLT2 inhibitor. So myocardial work is increased without increasing the myocardial oxygen requirement. This is what the importance of SGLT2 inhibitors. So all of us know that the heart of a diabetics and the heart of the diabetics which is treated with the drugs are different. The inflammation is more when the diabetic heart is not properly treated or not properly maintained sugars in with the sugar levels. So non-inflamed heart is always a better part. So what we are going to discuss today is a canvas program. The program of effect of this drug on the cardiovascular outcomes. So what is a canvas program? The canvas program is basically the program which is carried out in 30 countries. That means worldwide. All the races are included, right from the European, Caucasians, Asians, Australian, all of the Asia Pacific, Europe, all those countries has been included in these studies. There were 667 sites in this study. It has got two arms, that is canvas arm and the canvas R, where 4,330 and 5,800 patients. That means almost 10,000 patients were integrated in this canvas arm. It compared canagliflozin to a placebo. It has compared into different, in a canvas R, it has compared with the higher dose of 100 to 300 milligram, when in a canvas it is compared from the 50 to 100 milligram. So the dose variation was different in these two drugs. And there was a 2-week placebo run, that is with one with the canagliflozin 300 milligram, another with 100 and another with a placebo. So this is what the basic design of this study. The patients were included all were type 2 diabetes mellitus patient, where the HbA1c was more than 7 and less than 10.5. So it is the more than HbA1c more than 10 were excluded in this study. That is the most important things we should understand. eGFR should be more than 30. The patients with the mild to moderate to severe renal failure were excluded from this study. The age should be 30 years, and history, there was a history of prior cardiovascular events. And if the patient's age is more than 50 years, they were taken as the patient age more, the risk of cardiovascular factors, that is more than 2 cardiovascular risk factors. Like what are the cardiovascular risk factors are? Like diabetes of more than 10 years, systolic blood flow of more than 140, micro and microglobinuria, and HDL cholesterol less than 1. So these are the different cardiovascular risk factors which were taken into the consideration when including the patient. These are the different statistical methods used. The primary objective of canvas study was to find out whether canagliflozin decreases cardiovascular death, non-fatal MI or non-fatal stroke. That was the primary objective. Secondary objective, what was its effect on all-cause mortality and cardiovascular death? This was the secondary effects. And then other secondary endpoints were like non-fatal MI, non-fatal stroke, hospitalization for the heart failure, total hospitalization, the progression of albuminuria, what happened to the renal doses. Those were the points they wanted to study. So this study was actually started in 2009, and then it followed for next 11 years. These are the different criteria where the main, they were all matched. Most of them were age of 50 to 70, that is average age was 63. 35% of them were female. The duration of the diabetes was quite significant, that is more than 14 years, that is 10 years or 14 years. It is quite a long duration diabetes they have taken. Almost all of them had a hypertension when compared to diabetes, that is 90% of them had a hypertension. 14% were of heart failure patients, and 65% and significant more patients were in having a cardiovascular disease. Either they had acute myocardial infarction, either they had unstable angina, or any of the cardiovascular risk factors. So if you see the demography of all these patients, to whom you should use these drugs are the the patient who has got a diabetes, patient who has got a heart failure, and the patient who has got the cardiovascular disease already. Is also have a hypertension. The patient's diabetes is more than 13 to 14 years of a duration. So these are the subset which are actually included, or we should include when we think about giving these drugs to the patients. So this is just different kind of baseline therapies. All of them were on different therapies. 50% of them were on insulin. Rest of 50% were on the other oral hypoglycemic agents. 80% of them were on ACE inhibitor. That is the most important thing. And then around 73% were on antiplatelets and 75% on statins. So these were the baseline risk factors for all these patients. So what was the results of this patient? If you see, there is a definitely reduction in a mean HbA1c level when we give this drug compared to a placebo. It is oral hypoglycemia, acts as a OHA, so it has to do that. But it's a good control of HbA1c in all these patients. Effective on systolic BP, this is very interesting. So because of these drugs, there is a decrease in a systolic blood pressure from 138 to 130. That means almost 8 to 10 millimeter of Hg pressure differences was in a pressure of hypertensive patients. When we, the one whom we use canagliflozin. Body weight. Everybody will ask you about the body weight. So body weight is also controlled by this drug. So this affects blood pressure, this affects body weight, this affects diabetic level, that is HbA1c. Then we see a primary mess that we are thinking about, that is cardiovascular death, non-fatal MI, and non-fatal strokes. It has definitely reduced by the definitely reduced these all primary mess outcomes in all these patients. So hazard p-value is very, very good. That is 0.0001 for a non-inferiority, and for superiority, it has not shown much great influence on the p-value. So that means this drug is non-inferior to any other drugs of this category, but this is not superior to that. There is a definite effect on a primary cardiovascular outcome which favors the canagliflozin. All the primary cardiovascular outcomes has favored this drug. The MI component is definitely better with the canagliflozin. Stroke component is better. Definitely it affects the atherosclerotic lesion. It has got a statistically significant effect on all-cause mortality. This is also very, very important parameters out of this study. The hospitalization for the heart failure has definitely come down. That means quality of a life in a patient with the heart failure was increased. That is a good part when we use this drug. So summarizing the drug effect, there is a definite difference of a primary cardiovascular outcome. That is, CV deaths are less, the non-fatal MI is less, non-fatal stroke is less with these drugs. The hospitalization for heart failure has got a very, very significant effect if the patients with the heart failure and the diabetes comes to you. This is the drug which can we really think of. CV death or the hospitalization for the heart failure is less, and overall mortality is definitely reduced with these drugs. So these drugs with the that this is a good drug. This definitely decreases the all-cause mortality. It has got an effect on the blood pressure. It has got an effect on HbA1c. It has got an effect on overall diabetes control and the decreasing the cardiovascular mortality. There is a definite mortality benefit as well as morbidity benefit in view of decreasing or increasing the quality of life. But what are the safety outcomes? Because some of the serious side effects were observed in some of the patients treated with these SGL2 inhibitors. Most important out of them were male genital mycotic infections was observed in some of the patients, malignancies, photosensitivities, venous thrombolism, and increased evidence of fracture. Most important, some of the patients required amputations, acute pancreatitis, and diabetic ketoacidosis were also observed in some of the patients. So these were all fringe data. So we actually does not know whether these are the fringe data or this is the actual the effect of a drug. So for this parameters, Canvas study look after this kind of a safety profile. So whether these side effects are present with this drug. So if you can see this chart, that lower extremity amputations are definitely at the higher side when compared to a placebo in patients of a canagliflozin. But then highest levels of amputation, there is a definitely the hazard ratio of almost 20.9 when you see the multivariate analysis. The peripheral vascular disease, then HbA1c, all these are the same. But then when you do a multivariate analysis of this data, what it shows is there is a predictors of amputation risk are similar in both the arms. So definitely the similar effect for the malignancy. The data is not clear whether this is safe or unsafe. Renal safety is definitely it is safe in this issue. So what is the summary of our safety analysis when we talk about this drug is there is a newly identified increase in the risk of amputation. There is a possible increase in a fracture risk. There is an adverse event profile otherwise consistent with known effects of the canagliflozin. Means these are the known effects of the canagliflozin, though they occurred very fringely, though they occur in a very, very minor populations, but there is a definitely risk of amputation and the risk of a fracture risk in these patients. So there is another study called as in a Canvas R trial, which was carried out to evaluate this real world data with the retrospective analysis. And what is observed, the study says that there is a increased risk of below-knee amputations in a SGLT2 versus non-SGLT2s. And overall, there is an established cardiovascular population that the risk is comparative. That risk is not very high. This is what the final outcome. So FDA removed box warning about the risk of leg, foot amputation for diabetes on this medicine. So this is the recent guideline that what we were thinking about these drugs about increased amputations and the leg fractures. This guideline has been removed because of this newer data. So finally, what we are looking at is what are we doing actually? What are we, in which type of a subset we should use these drugs? So the patient who has got a type 2 diabetes of at least more than 10 to 12 years, patient who have got a high cardiovascular risk, like patient with the heart failure, with the diabetes, with the multiple pre-atherosclerotic events, the patient who are hypertensive, the overweight patient, oral metabolic syndrome patients, they have got a multiple comorbidities. 2/3 of them are because of the prior cardiovascular diseases. All those patients, and I personally recommend that these drugs we should not use still in a primary prevention because the safety data is not still clear. So the people with the high metabolic syndrome, patient with the diabetes mellitus of 14 years, with a high cardiovascular risk, overweight, hypertensive patients with the multiple comorbidities, I will recommend these drugs. Definitely, there is effect of biomarkers. All these biomarkers will be are less with these drugs, and we have seen that these drugs are better in this biomarker ability. So definitely, the patient with the acute coronary syndrome, patient with the heart failure, with the increased biomarkers, these drugs are again recommended. So finally, coming to last two slides, that there should be a comparison between the canagliflozin, dapagliflozin, and empagliflozin. These are the three different various drugs in the same category, and all of them are shown effective in all patients of diabetes, overweight, hypertensive, with the metabolic syndrome, with the better drugs. These are the different trials like Canvas, Declare TME3, Empower Reg outcome. All these three trials have definitely shown a better outcome with these SGLT2 inhibitors. Still, the use of these drugs in the practice is still less. The two reasons about this, the one is the fear of this amputation and the fracture data, which is still fringe, which has to be proved. Even though the FDA has taken out the these guidelines, it is we are proving this, but still it has not become a mainstay for treatment in our clinical practice. And number two, the cost of the therapy. This is also equally important in these cases. So summarizing my talk, that these SGLT2 inhibitors are definitely important in preventing the cardiovascular safety and efficacy. It is effective drugs. It definitely effective in a heart failure, definitely effective as a secondary prevention in a patients with the diabetes, hypertension, and the heart failure. It definitely improves the clinical outcomes in all these patients. But the increased risk of amputation, which should be taken into consideration when prescribing these drugs. as I said, FDA has removed the warning. We need some more data to actually test it against these drugs. And the favorable benefit risk profile at present recommend Canagliflozin treatment in many patients with the type 2 diabetes mellitus who are associated with high cardiovascular risk.
Let me start. The topic is physician, the healer and the professional. So I'll take you back to 1983 when I was doing my MD in medicine at the Wanless Hospital. And I declared a death. I just told those people, oh, so-and-so died. Told the watchman, because everyone starts crying, don't allow them to cry in front of the ICU. And that's that. Every day, 3-4 deaths used to happen in the ICU. I used to declare them. As a young person wanting to do medicine, it didn't mean too much to me. In 2017, a boy died of encephalitis under my care. And I couldn't get him out of my system. We had done everything for the boy. The parents appreciated what we had done. I went over again and again in my mind, could I have done something differently, to realize that nothing different could have been done. The boy slowly went down and died. And it took me 2 weeks to get that boy out of my system. I kept on thinking, he's a single child. The parents have gone back now to their hometown without a child. What will the family do? So between 1983 and 2017, what changed? So it dawned on me that physicians has 2 roles to play. One is that of a healer, and the other is that of a professional, which is then being a scientist yourself and then an organized service provider in the modern times. So physicians has 2 main roles to play, a healer and a professional. Now let's take a look at what is healing. Now look at the right top panel. That's from the native Indians in America. Healing doesn't mean that the damage never existed. It means that the damage no longer controls our minds. So healing is making people aware that the damage shouldn't lead their lives. Now, if you look at the history of healers, healers have been present for far longer than us allopathic physicians. You can see all different cultures, the American, the South American, the European, the Chinese, the Egyptians, the Greeks, the Romans, and of course the Indians, where traditional and spiritual healers have been present. They have been healing. Now, they don't practice evidence-based medicine, but they still heal. So I think it is very important for us to recognize that healing does not necessarily stand on the shoulders of evidence-based medicine. Please think about this. Healing doesn't necessarily stand on the shoulders of evidence-based medicine. Science stands on the shoulders of evidence-based medicine. And healing is a separate property to be learned and practiced on its own merit, just like we practice our scientific elements. So this is from William Osler on the left panel. A good doctor tends to the person who has a disease rather than just the disease itself. So science treats the disease, the healer treats the person who has the disease. So these 2 separate things need to be nurtured by all of us. Now, a healer's mindset is completely different from a scientist's mindset. For example, left hemiplegia is an infarct in the anterior branch of the MCA due to atherosclerosis to the scientist, but it is half a man to the healer whose half side is not working and therefore is suffering in his daily activity. Bilateral blindness to a neurology scientist is optic neuritis requiring workup to know why it is so, and is it neuromyelitis optica, is it MOGS, is it multiple sclerosis? But to a healer, it is a blind girl with navigating difficulties. So you can see how the perspectives are different. Now this slide elucidates the same perspective that I am bringing you up to. This is an actual fact at our Grant Medical College. See, at Grant Medical College, every Tuesday, traditionally, the exam-going students present difficult cases and the whole faculty of the department is present, and then everybody discusses them. So a boy presented a case of spinocerebellar ataxia with slow eyes, and 4 generations were affected because it's an autosomal dominant disease. So after the boy presented, the assistant professor, who is very young and wants to establish that he knows a lot, asked a question. Enumerate various types of eye signs that you see in ataxias and tell names of at least 11 syndromes that can do this. So he was still in the knowledge game. The associate professor asked, do you know who has worked on these diseases in India? And as some of you know, our department was the leader in this field, where Professor Noshirwadia was the person who diagnosed it. So he thought that the boy should also know who's worked on it. Then the professor said, don't forget to send him for physiotherapy and don't burden him in too many diagnostic tests. Because by the time he became a professor, he knew that the diagnostic test will not help this man's quality of life. And therefore, don't forget to send him to physiotherapy, which is what will help him. And then the head of the department turned to the professor and said, it is high time we looked at antenatals to stop the transmission. 4 generations already. So see, as the teachers have gone on, from teacher as a knowledge provider, has gone on to who's worked in this country, then to what helps physiotherapy, and then prevent it. So see how the perspective has changed from a scientist to a healer as time has gone by. But see, so much time has gone by before they have acquired this concept. So I very strongly believe that because we focus on the science and we do not focus on the healing, healing seems to develop very, very slowly, following the scientific knowledge by one's own efforts in his own lifetime as a practitioner. Now, we are supposed to heal. We can be healers. But the healer often carries some wounds himself, and that's where the medical training is an issue. Every physician, whoever I've spoken to, is a wounded healer. Now, Cheiron, some of you who read mythology will know that Cheiron was a mythological creature, a centaur, who was struck by Hercules with a poisoned arrow. And the arrow carved a wound that could not be healed. So he lived all his life with a wound, with severe pain, but he became a great healer of men and everyone else. So Carl Jung's Cheiron is a classic example of a wounded physician. Now, what do I mean by wounded physician? If you look at the training of physicians, the moment you remember your first house job that you did, you are the youngest. Everyone is continuously scolding you for things that you did and things that others did and things that happened. 24 hours have gone by, 3 shifts of nurses have changed. You have not had time to do anything about your lunch. You've not had time to do anything about your dinner. And still everybody is firing you. We are taught in our system that your time is no longer your own and your personal needs are irrelevant because people for whom you care have more needs than you. And that's a kind of a crucible on which everybody who goes into postgraduate medicine has to climb. That the concept of self-care has almost no meaning. As I grew senior in my department, when I went for my round, I used to go at 7:45 in the morning. I used to start round at the medical college at 7:45. I made it a point to ask everybody, have you had your breakfast? If somebody said he's not had breakfast, that person would go and have breakfast and come back. I think it has to be ingrained in us that self-care is not self-indulgence. We are entitled to the self-care if we have to care for others. So I think it is very, very important that our system, which is a hierarchical system driven by seniors towards their juniors, it doesn't carry the same nonsense that was meted out to them. And with every generation, the system has to improve to make our younger people sort of less wounded or not wounded at all. Right. Now, let's face this. Healing is the mandate of medicine. And how we arrange it, the hierarchy, the departments, the hospital, the professionalism in it, the corporate sector, is all how we organize. But what are we organizing? Organizing our mandate. What is our mandate? Mandate is healing. Now, having said that healing is very important, it's a separate property, it develops separately, and at this point in time, we are not paying enough attention to the healing, and that we have an army of slightly wounded individuals. Let me come to the actual problem, that what are the issues with development of the medicine man in today's India? And I'm sure you all will relate to this. Now, whom do we get to become doctors? Very young and very intelligent MCQ solvers are chosen as our new soldiers. The more MCQs they can solve, the more likely that they will get into the fold of medicine. They often do not know, believe me, I've done this study in the Grant Medical College and I'll show you a little bit of it. They do not know why they have entered medicine. They are just 17 years old. They can solve MCQs, so they are there. Very few of them, from my first-hand experience at the medical college, seems to know that they are in this game to help people. Now see some of these are actual clippings of medical students done at the Grant Medical College. Now see what this boy says. See, this boy says that it is my father's dream. My father wanted to become a doctor, but he couldn't become a doctor, so he asked me to become a doctor. What the hell? Did this boy want to become a doctor? Nobody asked him. He's been put into medicine because his father thought that medicine was a good career. This is another boy. So this boy is enamored by the general practitioner who was in his small town. When I asked this boy, did you know that your general practitioner is to wake up 4 to 5 times a night, every night throughout his life? He said no. He was infatuated by the respect that the man got, but he had no idea what his work was. So somebody's father's dream, somebody's flat infatuation with the job. So most of the boys or girls are there not for their own reasons, for reasons other than what matter, and a lot of them have no idea that they're supposed to help people in distress. That's their main job. Then what happens to them once we bring them in? We train them in a very, very competitive manner to become better than others in the class. That's the only thing that they are looking at, because unless they're in the first 3, 4, 5 or whatever, they're not going to get the post-graduation. So this aphorism sums it up beautifully. Two medical students are in a jungle and see a tiger. As one gets ready to run, the other asks him, do you think we shall outrun the tiger? The other one replies, no, I have to only outrun you. So they are sort of building against each other to be able to reach somewhere. So see, this is another boy who is asked, why do you read medical books? Yeah. So the whole thing on his mind is competing with his colleagues. See how different it is than what Francis Bacon said. Read not to contradict and confute, nor to believe and take for granted, nor to find talk and discourse, but to weigh and consider. Reading maketh a full man, conference a ready man, and writing an exact man. So we're so far away from the ideal reason to read. We just want to get more marks. So the early medical training involves competition, unmanageable load of information to be processed, and the one who processes more information gets more marks. And there is a need to score in the next examination. So students are populating libraries, and they do not spend time with their patients in their wards because that's not going to give them marks according to them. When undergraduate students were posted in neurology, I often ask them, why are you not coming to the wards when you're posted? They say, sir, we have to give an exam, we have to read, we have to solve the MCQs. So in the evening, you would find them all in the library. So a kind of misdirected sense of medical training has developed in our system. There are some other factors as well. One is that these are all very intelligent boys. You have chosen the most able MCQ solvers. So they have this intrigue of the rare and the unusual. And they neglect the garden variety diseases. They are focusing on what is rare. As you can see on the top right diagram, if there is a very rare disease patient in the ward, the whole medical student population will go and examine him, the like of which they may never see in the next 15 years. But ask them to see a simple chest tuberculosis, they're not interested. Ask them to see leprosy, no. See, every student who came with me to do DM neurology, I used to say, would you like to work on leprosy, tuberculosis, nervous system? No, 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 sir, no, no, no. And since I was interested in the myopathies and we were doing some pioneering work in myopathies in the country, if I would ask, will you work with me on sarcoglycanopathies? They'll say, yes, 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 please, please make me a part of this study. So it's the rare and unusual that attracts them. They don't realize that it is not the Einstein in them that they are satisfying. They are supposed to treat the common things well. And we are not imparting this on them. Those who know more rare diseases, we say, oh, this is a good student. So really, what is a good medical student? A good medical student is somebody who knows the common diseases well and can treat them well. But why does this happen? Because we have chosen the intelligent ones, and ordinary things do not satisfy the intelligence in them. Also, medical teachers are promoting this, that, oh, you have to know more. Oh, you have to know more. So the boys go on following that. So what has our system actually produced? Intelligent individuals, full of knowledge of the evidence base, They've developed an ability to work long and hard. And in that process, their self-esteem has got wounded a little. Their environment is quite unsuitable to develop empathy. In a neurology OPD at the Grant Medical College, the average attendance is about 100. And there are 7 or 8 boys and girls looking after them. What sort of empathy can you show? You're just trying to move 1, 2, 3, and finish the OPD, so at least you can have a little lunch. Also, they're not trained in empathy. Nobody has impressed upon them that empathy is necessary. And healer element, up till this point in their careers, has not been tapped. Then such people get into practice. When they get into the practice, there is an immediate identity crisis. When they go for an interview after having done, say, DM neurology, the interviewer asks, "Yahan to jitne aaye, sabne DM kiya hai, tune aur kya kiya?" So they come down to ground zero. And they realize that the corporate czars are dictating them. There is a price put on their efforts, and the corporate czar will tell what is your price. There is a need for them to acquire material things very rapidly in this fast-moving world. Their engineering colleagues are doing that. Their CA colleagues are doing that. So they want to do it. Everyone wants at the end of first year a good car, a good home, everything. And medicine doesn't give that sort of money that some of the other fields can give. So basically, they get into this rat race of trying to prove themselves in the materialistic world, taking help of the science that they have learned. And the healer properties in them remain dormant. And they will express or emerge with time and self-experience at a much later stage of the career. Happens to all of us, but slowly and steadily. And I think somehow we need to shorten that time. So I'm coming back to this question. What changed in me between 1983 to 2017? I think the healer element got strengthened in me. Now, this is the cycle that I have put out based on personal experience. Everybody's cycle will be different. As a young student, I started off thinking that competence is above attitude. I wanted to be competent. I wanted to know everything. And I thought competence is everything. Of course, my attitude was not bad, but it didn't matter to me. What mattered was competence. Then I became a neurologist. I started practicing, went abroad, broadened my horizons, came back, started practicing. And then I started enjoying, firstly, the diagnostic and therapeutic challenges. Or what is the diagnosis? Can I make them? I was sufficiently trained to make the diagnosis. How do I treat it? Sufficiently trained to treat them. So make the correct diagnosis, give the correct treatment, very, very happy. Then after some time, this joy started declining when I realized I'm supposed to make a good diagnosis. I'm supposed to give the right treatment. What is the joy in it? Then I realized that even though I'm making the right diagnosis, giving the right treatment, a certain proportion of patients' quality of life is not improving. That's when I first started appreciating the incompleteness of the science of medicine. At that stage, I thought, if I don't know, someone else will know. So I asked others, and I asked my teachers, and I asked everyone. And then soon I came to know that no one knows, because the science is incomplete. So a scientist who believed in competence realized the limitations of the science. Once I realized the limitations of the science, it was not difficult to understand the importance of compassion. Say, okay, I don't seem to be able to increase your quality of life, don't seem to be able to improve it. Let me at least be compassionate with you if I can't do that. So compassion started coming. And as the compassion grew, the healer element, that whoever comes to me should feel comfortable at the end of the consultation, started increasing. Now, around this time, many other things also happen. That your children grow, they go to schools, they go to colleges, you acquire enough funds that satisfy you. and most of the responsibilities of the worldly life become less. That is when, and I don't mind confessing this, pretty late in my life, the patient started coming ahead of myself. If a patient today comes to me, he is naturally ahead of my own thoughts, needs, requirements, whatever. I think it should be from the point go. But it's emerged quite late for me. That's because I am also product of the same system of which we all are. And I have come around a full circle now and believe that the attitude is above competence. If attitude is good, competence may come. If attitude is not good, competence may not have a meaning. Right. So the healer element, I strongly believe, need to be nurtured very early on. And to do that, we have to look after the physician as an individual so that he can look after his patients as individuals. If the boss doesn't ask you whether you had your breakfast and keeps on hammering you for where is the potassium and where is the sodium and why have you missed this and why have you not done X-ray and why don't you not do this, you will not create an individual. You will create an individual who is not being cared for, who will carry the same attitude for his students and for his patients as well. So I think it is the responsibility of all the teachers and senior physicians to try and nurture the younger one to become more satisfied and more complete individuals, not necessarily as doctors. Right. Okay. So to heal the wounds of the physician, to make sure that the physician comes out as a whole, we have to pay early attention to workload and work hours. I think it is high time we've accepted this, that we work for 24-hour shift and 36-hour shift. It does not work. So we've got to sort of collectively say, look, everywhere in the world, there is our system, that it has to be so in India as well. There is a role of faculty members of each department to ensuring this, and emotional support to young people. Like I distinctly remember one boy came who came from South India, and he became very miserable after he came to Bombay. And after some time he said, "Sir, I want to leave." I said, "What happened?" He said, "I just can't gel with the food. It's not possible for me to survive here." So I said, "Wait for a couple of months, see how it goes." Spoke to the canteen fellow to make sure that whatever he wants, he gets for those 2 months. And the boy hung on and then did his DM, then went to a Middle East country to practice and could do what. If that little support wasn't there, I don't know whether he would have stayed or would not have stayed. So I think seniors have a huge role in more than one way. We have to impress on them that self-care is not selfishness. I ask now every one of the person who's doing DM with me, are you exercising or not? Are you sleeping enough or not? Are you eating on time or not? I think we have to make them into good individuals. Self-care is not selfishness and is not self-indulgence at all. They have to be provided with all this. And if the system doesn't provide it, we have to make sure that the system changes. And looking after yourself, eating on time, sleeping on time is not incompatible with the life of service, which the medicine man is supposed to do. So look after the physician as an individual so that he can look after his patients as individuals. Right. I think we can take some cues from the role models, because role models inspire and they give you a belief about walking on the right path. See, previously there was this apprenticeship where after you have finished, you work with somebody who has a good name in the field, and then you learn the tricks of how they deal with patients or look at their methods, and learn humanitarian aspects, dressings and mannerisms, the bedside conduct, communication skills, and ability to solve daily issues. This comes from the role models. And some of you may know, here I'm talking to Ravi Shankar. Ravi Shankar is one of the premier headache specialists of India, and asking Ravi, what is the role of the role model today in the era of the Google? And this is what Ravi says.
Hello. Hello.
Yes.
Sorry, we cannot hear.
Okay. I think the voice is a little slow on that. Ravi is telling that the role of the role model is to tell you how you put what you have learned into your daily practice. It may be a shortage of resources, it may be shortage of time. How do you adjust that? So to go back to this slide, this is what Ravi said in that from a role model, you learn humanitarian aspects, dressing and mannerisms, bedside conduct, communication skills, and ability to solve daily issues. Actually, role models are everywhere. You need to search for them. Personally, I was very, very lucky to see fabulous role models. And this is Professor Noshir Wadia, with whom I was lucky to do this book, Neurological Practice, second edition. And great as he was, he called himself consulting editor and called me editor at the end of the venture. So you have to be slightly lucky and predestined to get a good role model, but role models are everywhere. Right. Then we come to society's needs and expectations. Society expects a healer to work as a professional, not professional to work as a healer. He has to be available, he has to be accountable, he has to be affordable, he has to be amicable, and if he also knows some knowledge, that's all right. So we focus on knowledge, but society is interested in availability, accountability, affordability, and amicability. Now, you learn this as you practice. No one teaches this to you. I think this has to be taught. Science is for you to make the diagnosis. Art is for you to impart what comes from the diagnosis to the patient. Right? And I think still a larger segment of our patients are seeking the healer in us. Like you see this all the time. Saab appointment nahi hai, par dur se aaya hu, dekhoge kya? Saab fees kam hai, chalega kya? Kuch bhi karke inko khada kar do. So they're actually seeking the healer and the compassionate individual in you, not necessarily the scientist. They may also know that ye khada nahi ho sakta hai, but they will still want you to say, I will try. Okay. Now see this example. This is from the movie Anand, where Amitabh is a doctor. And I hope you can hear this, or some of you must have seen this screen, this scene also.
We cannot hear.
No, you cannot hear?
No. I think
somehow on the Zoom,
make
this
some
voice is not
adjustment,
coming. Okay. No, this voice is full.
I think Mr. Prasad Sagar will be able to tell you.
Prasad, what
this
to
is
do?
Prasad. What I request you is that you can once again reshare your presentation, and during
No, Prasad, I don't want to do that. My flow gets disturbed. I will tell you what this
Yeah.
Now, if I keep my mic close to this, maybe you will hear. Let's see. Let's see whether this works. Is that working?
No.
No, sir.
No, it doesn't. Anyway, best way is you tell us what are they saying.
Okay, I will tell you. See, this is from the movie Anand, where Amitabh is a doctor and a cancer specialist. And this man comes in and Amitabh tells him that you have nothing. And the man gets very disappointed. He's not happy. Then he says, oh, I've got another complaint. I'm not sleeping at night and I'm sleepy in the day. So Amitabh says, look, you do not have anything. You do not have cancer. It seems that you are addicted to these rang birangi goliya. If I give you some tablets or capsules, you will become very happy. I think Amitabh here in this scene has given a display of scientific medicine. There is a man who comes asking whether I have a cancer. He says, look, you have no cancer. The man becomes unhappy. He fires him. The man leaves and says, look, there are many other doctors in the city. I can go to any one of them. So this is an exposition of scientific medicine, but a failed consultation. The end result is that the man went away unsatisfied. Now, if the healer mindset was awake, this consultation would have gone something like this. Okay, it's very nice that you don't have cancer, but you still seem to have symptoms. So let's address them. Let's give this and that. And the man would have become happy. Now, what do you want at the end of the consultation? You want a scientifically correct answer and an unhappy man? Or you want a scientifically correct answer put in such a way that there is a happy man? So I think the choice goes without saying. So, okay, we are all scientists. We have to practice our science truly to the best of our abilities. But it doesn't mean that that should cut the patient, cut his hope, cut his well-being. If you can do that, then you are the healer and the scientist in you both are awake. Now, I think there are new challenges. In organized medicine in the developed world, there are new challenges. That organized medicine has become impersonal. We have become parts of the wheel. We rely on evidence and statistics. We have become expensive. The insurance has put a stranglehold on all of us that they will give only this much for this and you do whatever you want to do. Then aims and objectives of the corporates have changed. And in all this, the role of physicians seems to be undermined. So I think it is very important that in medicine in India, which is trying to get organized, we still are able to practice solo and autonomy is still maintained. And I think if we can express the healer element, there is still a chance for us to do it. In some countries where organized medicine has taken over, that is almost impossible. So for the future of medicine in India, there has to be a balance between fully organized medicine and solo practices if possible. Indian society is still appealing to the healer in us and we should respond to them in a healthy way. Advocacy is needed in the right places, in the right direction to prevent our new generation of healers to become wounded before they start healing. And healer element should not be the last frontier. It should be the first frontier and therefore should be taught in medical colleges with as much gusto as the science is taught. So while we embrace organized medicine, there's probably no choice. We have to nurture the soul of medicine, and the soul of medicine is the healer, not the scientific facts. So this is Professor S.V. Sortur, with whom I did my MD in medicine, and I'm very proud of that period. Wherever else I went into the world, I never fell short of my general medical knowledge, thanks to this great man. And I have recently spoken with him and very happy that he's still practicing and very much doing what he's always taught us to do. And these are my neurology teachers. This is a very interesting photograph. These are all heads of the Grant Medical College. Neeta Mehta, Professor B.S. Singhal, Noshir Wadia, Sarosh Katrak, and me. Amongst 5 of us, we have led the department for 62 years. So each one has had 10, 12 years to go. And I think this department has been very, very lucky that there were these stalwarts. And therefore, I never had a shortage of role models, and I could actually see how they were working. And what healer element is, I understood. Like Dr. Noshir Wadia at the JJ, if he saw that some patient was very, very poor, he'll keep a 50 rupee note under his pillow. He will not even tell him. He will tell us, I have kept 50 rupees. Tell him to buy this, buy that. So we've seen teachers like that. And these are some of the people with whom I worked, Professor Byron Kakulas and Martin Pollock. And it was Byron who used to tell me that a neurologist is not complete till he's a neuropathologist. So he made me do brain cuts and standard neuropathology for 6 months, a full training of neuropathology. And that's Martin Pollock, with whom I learned the peripheral nerve teasing and stuff. So actually, it's been really a privilege for me to participate in this particular program, because it brings me back to where I started, and whatever I gained there in the medical college, in the civil hospital, in the medical college with a lot of friends, I tremendously cherish, and it laid the foundations to everything. And it is actually very kind of you to ask me to be here to do this presentation. A lot of people have helped me, and their names are here. Some took the interviews of doctors and other things. So actually, I've put together a song, but I don't know whether it will play, meaning whether you will hear it. Can you hear it at all?
No.
Can you hear it at all?
No.
No. Okay, forget it. The song is बहुत शुक्रिया बड़ी मेहरबानी मेरी जिंदगी में आप सब लोग आए. Thank you very much for remembering me. Thank you very much for remembering me. Thank you very much for asking me to be here. And it's been an absolute pleasure for me to participate. I'm quite open to questions, memoirs, and comments. Thank you very much.
Thank you, sir, for sharing your valuable thoughts through powerful oratory. Medical education or qualification makes us a professional, but sir, advice from you sure will make us to become a healer. Probably root cause of problems in recent times in doctor-patient relationship lies here. We want to be professional, and patient needs more healer than a professional. As sir said, we should aim for the balance between both. And the self-example he has given is really exemplary. Thank you, sir. Thanks once again. So now the platform is open for questions and doubt from the audience. And I request you all to type your questions in the chat box of the Zoom app. There is one question, sir. Whether tougher and rougher government rules are increasing the chances of physician not becoming healer but are even a professional?
Yeah, I think the time doesn't seem to be too good for the development of the field, because some forces, social forces, believe that a lot of us make only money and do nothing else. So more the reason why we should set good examples, so that people believe that we are here to heal and help people. And in that process, everyone needs money, everyone gets money, but money is not the primary objective. So in fact, more the reason why our whole profession should become a little more towards proving that, look, we mean healing, we mean to help. More the reason. Like when the going gets tough, the tough get going. This is the time for the tough to get going. Yeah.
So another question is, what do you think are the ways to improve the present system? Is the future bleak?
I really don't think it is bleak, because I am an optimist. But severe changes are needed. There's no doubt about that. Severe changes are needed, starting from the entry point. Like, I think the entry point should be open to anyone who has enough marks to get. And marks cannot be the only criterion. Like, I've seen so many in my practice who say, look, when my father died, I wanted to now become a doctor, but I'm 30. Now there's no way I can become. So it should be open for everyone. And then there should be a nurturing system so that they become comfortable. I mean, they're not dragged by the society for everything, and are practically haunted now.
Yes, sir. So my question, sir, actually what happens, as you said earlier, that as a professionals, we should actually aim for the healer. And as a society, I think still 80 to 90% doctors are very good. Means they are not,
Yes.
might not be that much healer, but they are aiming for it indirectly.
Yes.
So, and there are some culprits also in our profession, probably less than 10%. But what happens due to media, the society sees that a whole medical field is a culprit. So if we aim that our good things, means our healer side or our caring for the patient comes in forward by promoting good doctors from our side, and even punishing those doctors who are making some problems, some probably culprits. If we do that in front of the media and society, can we give the example like a soldiers? Soldiers is always respected. Doctors was also respected few years back. And if we give this example, we keep this example in front of the society, probably this will change. What is, sir, your view about it?
First of all, we are not organized enough. That's the price we are paying for our intelligence. Being intelligent, we all feel that we can work as separate solo units and we don't need anyone.
Yes.
See, a simple example I'll give you. Let something happen to a nurse. The whole hospital will come to a standstill.
Right.
Because the nurses know that they can't stand alone, they have an organization.
Yes.
Let something happen to a lady doctor in the resident quarters, even her friend will not help her.
Yes.
So our basic problem is lack of organization, which arises out of our intelligence, which makes us feel that we can work as solo. So there's nothing wrong, we are intelligent, but we should be intelligent enough to realize that as organized people, we will be much more forceful.
True.
What is our advocacy? Are any of our leaders, leaders of the API, leaders of whichever organization, are they able to put any pressure on the policymakers? We do not have any liaison. So actually, in many, many ways, we are good individuals working in a completely disorganized manner, trying to do our best and therefore failing.
Yes.
So it has to be an organized effort. Now, who and how will do it is another story.
Exactly, sir. Thanks a lot, sir. I see one question has come again. Just a minute. So actually, everybody is impressed by your lecture. So not more questions.
Yeah.
Thanks again, sir. Thanks a lot.
After such a knowledgeable speakers previously delivering a lecture, and now it's little lighter side. It's a voice disorders. As we say, voice is not only functional thing, it's a cosmetic thing also. You can hear this voice of Amin Sayani. All old people will know Bina Ka Geet Maula was a hit thing, and this Amin Sayani's voice was one of the identity. No one had seen Amin Sayani, but his voice always made his identity everywhere. So it's a cosmetic equally. Now you hear Amitabh Bachchan, who became such a big entity because of his voice itself. So voice is not just a communicable voice, it gives you an identity. So it's a equally cosmetic thing. Adam's apple, which is a larynx, which is a voice box, which produces a voice. You can know Shah Rukh Khan saying Kaka Kiran and his voice box throttling, and all girls used to really fall for him. So this is a cosmetic thing as well. How the phonation occurs, we must know first. This is what is a phonation thing. These are the vocal cords, this is the larynx, and you can see when they come together, they produce a sound. They need to vibrate to produce a sound. These are like strings. And as you know, like a sitar, if you have strings which are more stressed, then you have a little harsh sound. And now if you see, this is called stroboscopy, which is a very advanced diagnostic tool for voice. You can see they are coming together and they're vibrating. This is a slow motion picture of vibrations. And these slow motion pictures, we can diagnose the things very correctly, which we previously were not able to do. The stroboscopy has really changed the laryngology. Now, what are the functions? One is the airway, is a phonation. If you ask me, airway protection is the most important function of a larynx. You can see when vocal cords are away, they are open and you are breathing. But when you eat, they are closed, and they prevent aspiration and or what we call as a laryngeal penetration. A person who has lost his voice makes no difference to him, but if he loses his swallowing, If he starts aspirating, the life becomes miserable. All lateral medullary syndromes and many syndromes, patient really, I had a patient, he used to tell, he told me that every hourly, he at least has to spit 100 times. He cannot go socially. So it's one of the very important function of a larynx to protect the airway. Now, another thing is, vocal cords, they go into adduction, they produce a voice. They go away and they they allow you to breathe. Now, this is all your extra muscles, which are very important for your, these are like bhata of your peti, like the diaphragm moves up, your intercostal muscles, they act, your ribs act, and your breathing capacity makes a lot of difference on voice production. So those who have a chronic pneumonias, those who have a atelectic lungs, they have a very poor voice. Ultimately, how the voice is produced. This is the larynx, which is there. You can see the larynx is in the neck, where you have the thyroid cartilage, behind which you have arytenoid muscles and the two strings. These are the vocal cords, which move and they come together, and whatever the air has been delivered from the lung through the trachea causes this vibratory action of your vocal cords. And this movement is very important to give a quality to the sound. When they are away, they don't come very close. You will have a breathy voice, like patient will speak like this, because there will be no proper glottic closure. And you can see they vibrate. Up till now, till the laryngology developed, people used to say the vocal cords, they come together and produce a voice. But now it is realized the vocal cords come together and the mucosa on top vibrates and produces the sound. So what are the disorders you can get? So these are the infective disorders of voice, where these are the infections where you can have. Then I just want to mention that stammering is not a voice disorder. It is an articulation disorder. You can, patient coming with a stammering, he has a lot of tremendous inferiority complex in life. They don't go ahead in their life. So whatever this patient, they have to be assessed very separately. They need more of a speech therapy and not an exact laryngological treatment. So this I keep aside. Now, what are the common changes? The hoarseness, which is picked up very fast. Any minute, even a fraction of millimeter change in the vibrating edge of the vocal cord produces change in voice. The small irregularities also matters. Only thing is smokers, it is a little difficult because they have a typical smoker's voice. So I'll just briefly go through what are the laryngological findings. Mine is more of a visual and audio thing, because your visual impression is always better. And you can see this is called as subepithelial cyst, where you have a left vocal cord which is normal, and you can see a bump here or a swelling like thing, which is called as subepithelial cyst, where you have the cystic lesion formation because of the vocal cord, your mucosal glands. This is something hemorrhagic laryngitis. This has happened because someone has really exploded his voice. Those who are not used to speak very loudly or a high tone, and suddenly they land up with some conversation, they have a fight, or they try to sing in a very loud voice. There is subepithelial breakage of blood vessels and causes subepithelial hemorrhage. This is a classical example of a subepithelial hemorrhage. Now you can have this leukoplakia. The smokers, the tobacco chewers, you can see the white patch on the vibrating surface. The other right vocal cord is normal. The left is showing a white patch on larynx. It's a leukoplakia, which needs to be excised because and you have to really stop smoking. This is what is vocal cord cyst. You can see a cyst formation, and the remaining vocal cord is normal. This cyst is pedunculated or sometimes sessile, and when the vocal cords, they come together, it gets cramped inside in the middle and causes dysphonia. These are the different benign conditions. All these are benign conditions. This is a vocal nodule. These are callosity form. Actually, vocal nodules have different names, like a teacher's nodules. Those who teach very loudly in a big class, they keep on rubbing their vocal cords and they produce these callosities. This other name is Hawker's nodules. The third name is Of course, singers nodules. Those who are not used to sing very often and suddenly start singing, they may land up, or those who use bad vocal cords. And now another entity which we have observed is mothers' nodules, because I've seen mothers really shouting their children a lot and developing this change in voice. This is a very typical intubation granuloma. Those patients who have been admitted on a very long time with a endotracheal tube and on a bed. You can see this is a posterior glottis where you can see a big swelling formation, and similar swelling may appear on the other side also, because this is because of the chronic rubbing of your endotracheal tube. And these granulomas are in fact known to recur even after we remove. This is a typical picture of your ring case edema. The ring case space is a space, it's between your vocal ligament and the mucosal surface. If there is a edematous collection, this very commonly occurs in pediatric age group. And when this occurs, they may land up with stridor. You can imagine in vocal cords, if in a small child who has a larynx of 4 millimeters, if this ring case edema occurs, his 70% of airway gets blocked, and these children commonly land up with stridor as well. Stridor is a noisy respiration. It's something like this. So these needs to be treated. Sometimes you need to tracheostomize these children, because intubation is also sometimes very difficult. This is a typical cyst. It's a cyst form on the vocal cords. These vocal cords are normally, they are very much moistened by the glands which are there on the surface as well as the ventricles of the cords. And if some gets blocked, it's a retention cyst, which is also commonly seen. Now is the adult laryngeal papilloma. It looks like a malignancy, but it's a papilloma virus infection. Many times it's a papilloma virus infection, produces a typical mulberry-like thing. It's known to recur again and again. And you can see a big mass coming, patient goes in a stridor as well. So this is a benign condition still. You need to biopsy, and after the biopsy, when it's not a malignancy, you need to treat it as a benign condition. This is a subglottic cyst where you can actually see a cyst on the supraglottic cyst on the superior surface of the larynx, obstructing the patient, causing airway obstruction. It's a video laryngoscopy, the nasopharyngeal laryngoscopy, where you can directly go and nicely see the big sick cyst which is flapping with and causing airway obstruction as well as change in voice. So this is another condition. This is again a granulomatous lesion. You can see when you have a fleshy granuloma on the larynx, this is a trachea, this is the vocal cord, and you can see the blood supply. The blood supply to this lesion has been increased. You can see the blood vessels running across. And when you really operate on them, you need to cauterize these blood vessels or vaporize these blood vessels. Otherwise, they may recur. So this is what happens when patient speaks. The left vocal cords gets really pushed, it gets indented, and there's a change in voice. So voice change has to be really looked for. There are lot many benign conditions. Every voice change which has not settled within 15 days needs to be assessed very properly, because what we see many a times, these patients have been not guided properly. They have been treated with, oh, you must have used voice more, you must be eating something, or your cold must have happened. But it is not so. Unless you open up your fist and see what is there in the fist, you cannot comment on the change in voice. This is another entity called atrophic laryngitis, where you can see there is sicca laryngitis. Sicca is a dryness of laryngeal mucosa, and this is a very troublesome condition because even the medical line of treatment, surgical line of treatment doesn't help. This is a pediatric papilloma. You can see a big papilloma in a small child. This is a very common condition in a very low economic group, socio-economic group. Nowadays, what patients we get are more from the Karnataka area, North Karnataka. And these children land up with hoarseness initially. Many a times they have been treated as asthma. They have been given a lot of asthmatic treatment, and when we scope them, we see a papilloma formations on the larynx. They come in a very bad obstructed shape also, and this is known to recur till the age of 12 years. So till the age of 12 years, we need to keep these patients alive. Sometimes if it's happening, recurring very often, we do a tracheostomy for these patients. Many a times, these patients, they are born by natural delivery. Those mothers who have papilloma viral infection of genitals, it is said that when you have a normal delivery, the larynx get infected, inoculated at that time. It's one of the theory for pediatric recurrent laryngeal papilloma. This is a laryngeal tuberculosis. That is also not very uncommon. This is a typical picture which looks like malignancies, basilateral and very edematous thing. We did the biopsy. When we treat them with anti-cox treatment, they genuinely subside completely, leaving no scar on the larynx. So it's a very miraculous result with the anti-cox treatment. So what we do is we need to assess these patients. We have to do OPD procedures like a dynamic video endoscopy, where we have a stroboscopy. It less time consuming. It's no effects. Don't require anesthesia. The cost is also not very expensive, but you can see a proper larynx in this. This is what is the procedure being done, where you need to, even we can do the biopsy. You can see in the OPD without giving anesthesia at a very low cost. We can do with the forceps. You can take the biopsy of the larynx. You see the vocal cord which is thickened and the lesion on this. This is a very simple OPD procedure which gives a good idea about the larynx. Even small children, day one child, we can scope them. This is a small child. You can see we are not anesthetized, so the risk factor is very low. We're doing the scoping in the OPD, just tighten up the child, and we have a scope which has a diameter of 1.8 mm, and we can pass the scope, nasopharyngo laryngoscope. We can see the larynx, and we can diagnose the many pediatric conditions with voice change. A small child, we call it voice change when they have a different cry. So these are some congenital lesions where you have a now you can hear the sound of this child. It's a very typical, it's a incomplete glottic canalization. You see a web in the larynx. The laryngeal opening posteriorly you see, but there is a thick wave here. And the voice of child, cry of child is like this. We had to operate this. Another child who was very breathless, you can see a stridorous child. And when we did the scopy under local anesthesia, because submitting the children under general is very difficult, we see a big fleshy mass coming out from the larynx and subglottis. So we operated with the laser. You can see it's been completely removed, and the child is now very nice. He is completely changed. Facial edema is gone, and he has a good, wonderful voice. So this is another condition where you have a laryngeal tracheal stenosis with complete obstruction of child. We have different things to put into the larynx. This is a T-tube where we have made a child comfortable with his breathing, as well as we have made him speak also. So he can go and attend the school. You can hear the sound after we did the T-tube administration. Another child who can see, you can see her voice is, she was obstructed, her voice was a thing. When we did her scopy, we saw a larynx being completely blocked by a big swelling. It was a cystic lesion, which we endoscopically removed with the laser. The mass was removed, the vocal cords are now very visible, and child became very comfortable after the thing. So the diagnosis of a benign condition with good laryngoscopy is very important, and then the decision has to be taken what type of, with the advancement of laryngology, we can clear most of the vocal cord anomalies or vocal cord pathologies very comfortably. Another child suddenly stopped talking. When we did the scopy, we can see it is very surprising the child survived. We can see a piece of coconut being strangulated in between the two vocal cords. His voice was affected. He could breathe from both the sides. So these are the very big advantages of doing a veriscopy. I had one very funny patient who had came with a change in voice, and we did the scopy immediately, and we saw a full grown-up honeybee into the larynx. How it went, I don't know, but it was nicely removed, and the child was comfortable. Another very important thing, many times patient they come with a change in voice or absent voice. Suddenly, Dakhili Basli, and see this girl. We did her stroboscopy. Stroboscopy was normal. She was going around with this voice for more than 6 months. We did the scopy. We found nothing abnormal. We just gave her a few irritant smells, and you can hear the sound. Very next moment, she started talking. This was a functional dysphonia, and they need a further evaluation after psychiatric evaluation after this. Another very important thing which has changed the laryngology completely is your thyroplasty. Here you can see a 18-year-old male with a voice. You can see his voice. This was not giving him confidence anymore. He has tried all speech therapy. We did what is called as thyroplasty. It is done under local anesthesia. You can see the larynx has been exposed and is talking while we are operating. You can see the larynx has been cut in vertically, and we did a type 3 thyroplasty, and he has a now grown-up male voice. As I said, your voice is an identity. Suppose a beautiful patient lady comes in front of you and starts speaking in a manly voice, you feel very odd. Even they are psychology very much disturbed. Even a male with a big mustache comes and starts speaking in a very feminine voice. Again, it's a problem. I had a person whose name was Bala Sahib, and he said, I have a problem that everyone calls me Balabai. So he was very much disturbed. So this type 3 thyroplasty really gave him a very useful thing. This is again a fellow. He was saying that on phone, everyone was saying, yes, madam. And when we did the scopy on tape thyroplasty, you can see it's. This is a developmental pathology. You can see his voice. So this has really changed field of laryngology and the concepts of laryngology. Now this person who is a executive, he said, every interview I go, I'm failing because of my voice. And you see after the procedure, it's on the second day. See, this is a wonderful thing we get. Now another thing is medialization thyroplasty. Vocal cord paralysis. When I was in college, I was a student. The only treatment for vocal cord paralysis was wait and watch, or you give a lot of speech therapy. And those who never improved, they always lost their voice. But with the advent of, this is a Ishiki. He's a Japanese person who is 85 now. He's a very renowned Japanese laryngologist who has developed Ishiki's techniques of thyroplasty type 1, type 2, type 3, all done under local anesthesia, exploring the larynx. And I really had a privilege to have a workshop with him. And he made a nomenclature as laryngeal framework surgery. And we have this thyroplasty in it. And what is done is, here the larynx is cut open, a window is made under local anesthesia, and a silastic block is pushed inside to change the shape and size of the vocal cords. And it gives really wonderful result. On top of that, myself and Dr. Yande from Pune, we have made another technique in this. We started using screws into the larynx. Instead of making a window, we have started putting the screws to medialize the thing, and there it's working really well. So this is a vocal cord palsy. His voice you can hear. It's really not audible. It's not very understandable. And after the procedure, you can immediately see the difference. So dramatic results you get with this all thyroplasty techniques. This fellow, again, he was a Maula in one of the masjid. He lost his voice, he lost his job. So he said, no, I want my voice back. See his voice immediately after the procedure.
Allahu Akbar, Allahu Akbar. Allah, Allah.
Another lady lost her voice. She was very much disturbed with that. We did the thyroplasty and the local anesthesia. You can see the larynx getting and see the final result.
Namo Rihantanam, Namo Siddhanam, Namo Aliranam.
So this is what miracles it has made. Another point I need to stress is, I'll just wind up within two, age and voice. After the age, many patients say that my voice is getting fatigued. Now I'm 70. I was used to, yesterday only one lady said, I was a teacher, I was teaching so many hours. Now even I cannot take my, even the studies of my granddaughter. So what happens is there is a lot of bowing, the cartilages get weakened, their muscles get atrophied. And but I always give the example to her that, see, this is Lata Mangeshkar, who is a renowned singer, singing in 1963. You can see her voice. And see what she sings in 2014. Even though she is very audible, she is very beautiful in singing, you can appreciate the difference between her singing qualities. Because every 10 years, every decade, there is a change in voice. There is a more broadening of your voice. And that is a age-related process, and that cannot be reversed. You only can make riyaz, or you can go with your speech therapy, try to maintain the quality of voice. But every 10 years, there is a fading of your voice. Another is very important is acid reflux. Many patients do get cured with acid reflux. So we tell the GRD, LPR, this laryngopharyngeal reflux is very important as compared to GRD for us. We have to diagnose and treat that. So reflux is another very important thing for us. And cancer, smoking is important thing. Smoking along with alcohol is supposed to be the worst enemy of your larynx. So take care of that. You have to stop that. And this is a laryngeal pictures. You can see the malignancies of the larynx very badly coming. But now translaser or oral laser surgery for a larynx has been getting very much promoted. We do initial growths, type T1, T2 lesions with the endoscopic laryngeal surgery, and they are doing really well. This is a patient operated by me 5 years back, 6 years back. You can hear his voice. He's very comfortable. CA larynx. So this is what is coming. Those who've gone for a total laryngectomy, the voice reconstruction again is a challenging thing. So now what we do is that TP fistula, tracheoesophageal fistula. This patient who has completely lost his voice, they become, you can see on his face how depressed he is. There is a Blom-Singer prosthesis where it's a very simple thing. You get this prosthesis, if you fit it, you can see his voice now. Even though the quality of voice is not there, but he can be a part of the society. He can communicate with the, his families and close associates. So this is a post-laryngectomy speech. Another fellow, you can hear, he has a permanent tracheostoma, but with the Blom-Singer prosthesis, he's talking. You can completely understand his speech. This is a pharyngeal speech. Actually, we are diverting his larynx towards the pharynx. So don't smoke. And one of the key things, I'll just sum up, the hydration of the larynx, where you need to hydrate your larynx. We always, patient tell us that I drink 5 liters, 4 liters of water every day. For us, for a laryngology, we need multiple times of water drinking. We tell them you every 20 minutes you drink water. So instead of putting like Pataza Pani, I always tell them you put a drip irrigation in your throat. That definitely will solve your problem. So laryngeal health, your fitness again is very important. Unless you have a good breathing capacity, your good stamina, your voice will never be a good voice. So this is what is important. And so quit smoking, drink water. And I explain my patients, your voice is a very precious thing. Your voice is given God gift. Never use it for shouting. We never say that animal. We always say putra oradto, manus bolto. So never change that. So I think this is a good take-home messages. And it's really wonderful joining all of us, all of you and everyone. I thank the President, Secretary and the team of IMA for able to share my views with everyone. Thank you very much for inviting me. Thank you very much, ma'am.
Yeah, so a very good afternoon, good Sunday afternoon. As my dear friend Ashok just mentioned, it is a very daunting task to make a presentation on an afternoon post-lunch, that to a Sunday. And especially after a very mesmerizing talk by Dr. Ashok Purohit sir, a very beautiful audiovisual treat. I hope that I'll be able to keep people awake for the next 20-25 minutes. And if at all you are awake, I hope that you won't get the sensation of vertigo, what we are going to talk about. So my topic today is updates in vertigo management. This is the beautiful movie, 1915 movie by Alfred Hitchcock, and vertigo hasn't changed, but assessment and management has definitely changed since that time. As we know, vertigo is an illusion of motion, and vertigo is supposed to be so common that all of us who are here on this online platform will eventually encounter it in their patients, or if you are lucky enough not to encounter, then you will experience it sometimes as the age progresses. But the good thing about it is that the vestibular disorders are so treatable that it is an immense advantage to know how to assess the vestibular system. So everybody of us should know the basic assessment of the vestibular system. So what is my plan for today? My plan is that I'll just talk very briefly about the vestibular system. Then, rather than going into the theoretical details, I would talk about common case presentations and then what are the updates in their management. And then what is a present day vertigo lab or a vestibular lab as they call it, or what is the concept of a vertigo clinic. And if time permits, we will have a sneak peek into the future. So as we all know, the vestibular system consists of the central and peripheral parts, and it works in tandem with the ocular and somatosensory system. The vestibular system, for your information, is one of the oldest systems which were acquired from the primates and is responsible for equilibrium, balance, and orientation in space. So if you don't have vision, if you don't have hearing, the human being can survive. But without your balance, it is very difficult to survive. Now, these sensors which are located in the membranous labyrinth, which is in turn located in the temporal bone, has got a silent set of sensors. What do I mean by silent? What I mean is that routinely, as such at rest, we are not available of the functioning of the system. We are available that we are seeing, we are available of vision, we are aware of it, we are aware of hearing, but we are not aware of our balance system. So we only become aware of the system when there is a malfunction in the system. So that is the importance. Receptive hair cells which are located in the labyrinth are mechanoreceptors, that is they detect mechanical energy and they detect rotary and linear head movements at rest and during motion. The vestibular nuclei are located in the medulla oblongata and they have afferents on the vestibule itself, the visual and proprioceptive systems, and they have afferents to the skeletal muscles, the extraocular muscles, and to the cerebral cortex. And of course, the cerebellum has got a regulatory role too. Now, the malfunction in this system results in postural instability, spontaneous nystagmus, which you are going to see later, and vertigo. Now, if you see the list of diseases which can cause vertigo, it's a very long list. This is a very short list which I have prepared, and the common diseases like BPPV, Meniere's, vestibulitis, bilateral peripheral vestibulopathy, not to forget vestibular migraine, they are all seen by all of us. So, rather than going into each and every pathology, which is of course impossible in this short time, what I would do, that I will take a few selected cases and then share my views about the management of these cases. Now, vertigo can present in three forms. It could be an acute presentation, first presentation, it could be a chronic sort of vertigo, or it could be a recurrent vertigo. So now, my first case, this was a 60-year-old hypertensive lady who presented with acute onset giddiness, and a left-sided hearing loss and tinnitus since the last 3 days. She also had nausea, vomiting, little bit of headache, blurring of vision, and difficulty in speaking and imbalance. The moment she entered my OPD, I noticed that she had an ataxic gait. She had an hypertension. When she started talking, she had dysarthria. She had a grade 2 upper motor neuron type facial palsy. And on testing, she had facial numbness and loss of temperature and pain sensation on one side. ENT examination was not much except for a little bit of bilateral moderate hearing loss expected as per her age, but she had a classic ataxic wide-based gait and a veer to left on testing and a dysmetry and dysdiagenesis. Now, how did I go for further diagnosis? So I went to a targeted test battery, which I'll come to very shortly. Then we perform a lab invasive. Just I examined the reports and she had dyslipidemia and left ventricular hypertrophy. Considering thinking that this is something sinister, we did an MRI brain with diffusion weighted images, and as expected, it turned out to be a cerebellar infarct in the anterior inferior cerebellar artery territory. So now here comes the question, how to differentiate a simple benign vestibular neuritis from a cerebral stroke, because they will have exactly same clinical presentation. So there are some cues. So what are the cues? You look after the symptom severity, onset. It's a very sudden onset, like a lightning from the skies, then more likely to be central pathology. If the progression is rapid and there is no relief in between and it lasts for days, again it could be central. If there are risk factors like age, hypertension, dyslipidemia, diabetes, IHD, again that goes more in favor of cerebral stroke. Then we have got something called as a Hintz test battery, which has got a sensitivity of 100% and specificity of 90%. This is one of the updates which I very much wanted to share with you, because it's a very pure clinical sort of examination which you can do at the bedside. Why is it important? Because it has been said that 10 to 20% of patients with an acute stroke may have a normal MRI in the first 48 hours, and this highlights the importance of the bedside targeted clinical examination. So what is that? The first thing is a head impulse test. So how do we do it? It's a small video. See, you thrust the head of the patient, move the head about 10 to 20 degrees to the left and to the right, and ask the patient to look forwards. If the patient can hold her gaze during this moment, this is a negative head impulse test, which indicates it's a normal vestibulo-ocular reflex. Now, if the vestibulo-ocular reflex is normal, that means it's not a peripheral vestibular pathology. So, in a case of acute vertigo, if the vestibulo-ocular reflex is normal, that is normal head impulse test, it points towards a central pathology. Remember this. Normal test, central pathology. Abnormal test, peripheral benign pathology. Next, to help is the nystagmus. So you ask the patient to look to the left, ask the patient to look to the right, and then again upwards and downwards. Now, if in this case you get a gaze probe, direction changing nystagmus, and vertical nystagmus, again it is very much likely to be a central pathology. And the last thing is that you do something called a rapid alternate eye cover test. You cover eye rapidly and you look at the axis of both the eyes. If there's a change in the axis with this rapid test, it's called a skew deviation. So if a skew deviation is present, again it points towards a peripheral pathology, towards a central pathology. So all these three things together, that is a head impulse test, nystagmus, and a skew deviation. So a negative head impulse test, an abnormal nystagmus, and a positive skew, central pathology, cerebral infarct. A positive head impulse test, no nystagmus, or a very benign type of nystagmus, and negative skew that goes in favor of an acute vestibular syndrome or a vestibular neuritis. So this was the first case. Second case, this was a 22-year-old female patient who presented with vertiginous sensation on turning head to one side. This vertigo was momentary, lasting for only a few seconds or occasionally 2 minutes, especially on turning to one side in the bed or looking up or bending forwards. She had no audiological symptoms. A general and ENT examination was normal. CNS examination was normal. And she only had a positive positional test on neurootological testing. So what's that? So this is a Hallpike's positional test. This is a very small video. From a sitting position, you rapidly take the patient down 30 degrees down and 45 degrees to one side and you observe for a nystagmus. And I will show what that nystagmus looks like in a minute. So this is called a Hallpike's positional test. So there is another test. So that is called a macular Panini maneuver or a supine head roll. This is for a different type of BPPV. So look at the patient. you rapidly turn head to one side and just look carefully at your eyes, and you can see that robust nystagmus, very classical, which you can't miss. Anybody can see this nystagmus without any glasses, without any video frenzel. So this is the classical horizontal nystagmus directed to left and directed towards the earth, that is called geotropic variety of horizontal nystagmus. So what are we dealing with? So we are dealing with something called as BPPV. So what is this BPPV? So this BPPV is one of the most common peripheral vascular disorder, and the pathophysiology, free floating particles or autoconia in the semicircular canals here, as you can see here, the laser pointer, or on the cupula of the ampulla of the semicircular canals. Now this could be post-trauma, which could have occurred years back, or secondary to infection, and this leads to an increased inertia of these particles, which stimulate this sensitive organ in the ampulla, which for a stimulus which is not enough to stimulate, these heavy particles will stimulate the cupula and lead to a sensation of vertigo. So all three canals can be affected, the posterior, the lateral, and the anterior, but the posterior canal BPP is the commonest. The diagnosis is again by those maneuvers like Dix-Hallpike and supine head rolls, and the treatment is very simple because this is a mechanical problem. The treatment is purely mechanical, and you do something called as particle repositioning maneuvers, and the famous ones are the Apley's maneuver, Simon's maneuver, and many other maneuvers. I have not covered those maneuvers. They are all available on net, and they take only a couple of minutes to perform. The patient will absolutely go home free of symptoms. And I've been following this patient for years together, and they have not got any symptoms, therefore, more than 90% of patients. And the good thing about it is that they bring you many patients. Sometimes the patient will not have BPP, they will ask you to perform this variance. That is the bad thing about it. So this is a very simple pathology. If you make a diagnosis, the treatment is very simple, no medicines, no investigation, and patient can go home free of symptoms. Now, there are some refractory cases, and there you have to go for surgeries like singular neurectomies or transmastoid occlusion of the posterior canal, but these are very, very rarely required. What are the advances? Advances that we have realized over years that BPP is not simple, so simple as it appears. You can have multi-canal BPPVs, so at a time 2 canals will be involved, one on either side. You can have a canal switch that you treat one canal and the other canal gets affected, or you can have something called as malignant paroxysmal positional vertigo, where it's a central pathology, often a tumor, which masquerades as an BPPV. And you have to have a very proper neurological examination to be able to differentiate. Now, you can use something called as a rotary chair, which is commercially available for exact localization of the canal and a target therapy. And we'll come to that when we talk about rehabilitation. Now we come to the next case. Now this was the middle-aged male who presented recurrent attacks of giddiness for last few years, which was accompanied by fever, nausea, tinnitus, and heaviness of 1 year. And each attack lasted for few hours, as against what we have seen in BPPV. Again, the general and ENT examination of normal. He had a little bit mild veer to one side on the Fukuda stepping test, and an audiometry showed moderate low frequency SN loss on the one side, and the specialized tests like CC and ABLB were positive. We did something called as glycerol dehydration test. That is very simple. You do fixed amount of glycerol, you check the osmolality, plasma osmolality, and you do a prior audiogram and audiogram after the glycerol test. If you have a 10 dB improvement on that audiogram, that is very classical of a Meniere syndrome. And if you do a test like an ENG or VNG, which you are going to discuss later, you should have an hypoactive response on one side. And the imaging is, of course, normal. So this is a classical Meniere disease. And this is a picture, a pathological picture, a very famous picture of a ballooning of the endolymphatic sac. Now, this entity was described way back in 1861 by Prosper Meniere, a great physician. And the pathology, as we saw in the last slide, is an endolymphatic hydrops or ballooning of the endolymphatic duct in the cochlea and the saccule. And the diagnosis is clinical. The classical triad of giddiness, hearing loss, and tinnitus. We can perform the glycerol dehydration test and electrocochleography or REM. These I'm going to speak later. Now, what is the advances? There are advances in imaging, and nowadays a 3 Tesla MRI with an intratympanic gadolinium can give an excellent demonstration of this typical hydrops. And you can very well differentiate from a normal endolymphatic system. So MRI has made great strides, and if you have a good MRI at your place, then you can very easily, with confidence, diagnose Meniere's disease. Treatment, acute attacks you treat vesicular sedatives, whatever available. Then maintenance therapy is, of course, a dietary salt restriction, diuretics, and sometimes you have to give a drug like betahistine for a long period. There are many surgical treatments which are advocated, like endolymphatic tract surgery, vestibular nerve section, labyrinthectomy, and cochlear implantation for hearing loss, the last stages. But many of the tests have not stood the test of time, and we have got a very simple treatment for this, which is called as intratympanic gentamicin therapy, which I practice in many of my patients who have got a very resistant type of Meniere's who do not respond well to medicines. And here you can give on an OPD basis intratympanic routinely available gentamicin, or maybe you may repeat a dose for once or twice and you get excellent result as far as vertigo is concerned. And then you can go for an endoscopic selective vestibular neurectomy. That's our Meniere. The last case, this was a 40-year-old female patient who presented with recurrent episodes of giddiness lasting for a few hours. She had history of recurrent headaches in past, and on inquiry, she had focal and photophobia. General and ENT exams were normal. Neurological exams were normal, except for a little bit sway. Audiometry normal, imaging normal. And then this is a classical case of migraine associated or migraine-related vertigo, which is the second most common cause of vertigo. And as per the international classification, you could have a definite or a probable vestibular migraine. Again, the diagnosis here is by exclusion. You'll have a typical normal physical and neurological examination. Investigation will be normal, but the history will be very classical, and investigations are to be performed only to differentiate it from diseases like Meniere's, vestibular neuritis, BPPV, vertebral basilar insufficiency, or episodic attacks like Friedreich's. Treatment is again same, to do a trigger avoidance, use dietary measures, lifestyle modification, easier said than done, counseling, stress management, and acute attacks, of course, you have to treat with vestibular sedatives. Again, prophylactic therapy in the form of beta blockers like propranolol, tricyclic compounds like amitriptyline, sonorizine, SNRIs like venlafaxine, and antiplatelet medication like topiramate and gabapentin. And the doses you may have to titrate depending upon the symptomatology of the patient. So after we have discussed these 4 cases, which are just representative, because it is almost impossible to cover each and every case, now we come to our modern day vestibular lab or vestibulometry. So what is the importance of the vestibular lab? Nowadays, with the available tools, we can literally pinpoint or localize a vestibular pathology. We can tell which sided vestibular nerve is involved, right or left, whether it's the superior vestibular nerve or the inferior vestibular nerve. Is it the right sacroiliac involved, or is it the left utricle which is involved? So we have a good set of investigations like an ENG or a VNG, that, or you can have something called a video head impulse test, OVEM or CVEM, subjective visual vertical, dynamic visual activity, post-urography, and craniocartography. Of course, allied tests like Lewton audiometry, BERA, electrocochleography, nerve conduction velocities, imaging studies like a 3 Tesla, MRI, and transcranial Doppler. So we are going to see a few of these. What is video nystagmography or video oculography? It's an electronic scanning of the eye movements using high-resolution cameras, and you can perform all routine tests like oculometer tests, caloric tests, and position tests by using this system. So a small video of video nystagmography. Give me a second. So this is a video of VNG. This is a courtesy of Neuroequilibrium, who have been kind enough to give these videos, and it's an Indian company, a very good quality of vertigo equipment. So the patient is asked to perform some tests, and the recording of the eye movements, or actually the corneo-retinal potential, is done and is presented in the graph form. And depending on the results, you can come to a conclusion. So this is a video nystagmography, and this is how a horizontal nystagmus will look on an VNG. So see, very classical, very small nystagmus which are not seen by naked eye are depicted very well on a video oculography. So this is horizontal nystagmus. Then we come to vertical nystagmus. So again, observe, you can see the cross. You see the pupil and the cross, and you can see the eye movements. So this is again a vertical nystagmus, which is very well seen on a VNG. Then we have seen the horizontal canal BPPV. So how will it look on VNG? See, very classical, very robust horizontal nystagmus directed to one side. So this is how a VNG will give an excellent recording, very robust recording, and you can come to a very perfect diagnosis based on this. Then to the video impulse test. This video head impulse test is a slightly extended or an advanced form of the head impulse test which you have performed, and it's very simple again. The same system you use, the camera is mounted, and then the head impulse test is performed by the examiner, and you'll get recording, and you can see whether they are sacchards, and there are various varieties of covert sacchards and overt sacchards. We won't go into details, but that can again help us to differentiate between central and peripheral pathologies to a very great extent. So then we come to something called a subjective visual vertical, which is again the most consistent test for unilateral ocular dysfunction. And it's very simple, easy, accurate, and you can test the verticality, which you are not able in other tests. So how is it performed? Again, it's simple. You ask the patient to wear the goggles, and then you ask them to localize the visual vertical. And a patient with unilateral vestibulopathy will not be able to localize the visual vertical, which is straight. And then you can plot the difference between the normal control and the affected patient, and you can get a lot of information depending on this study. Then something called a dynamic visual acuity. Again, it's a functional test for video ocular reflex. Again, it's very important for bilateral peripheral vestibulopathy. And another important test is that it's an early sign of vestibular toxicity. So patients who are on vestibular toxic drugs like streptomycin, kanamycin, gentamicin, or multiple drug-resistant tuberculosis, it's a very good test. And again, it's very simple. It's something like a Snellen chart. You perform a head movement, and you ask the patient after a head movement to localize the chart and identify the alphabet. And this can give us a lot of information. So then there is something called as kinesiography, where you do a photographic recording of the patient's head and body during gait, and then you can do a Romberg, Standem, Unterberger's test. And this is the goggle which is used for the test. And this is also very important, not only for diagnosis, but also for gauging what is the rehabilitation or how much recovery has occurred in a particular type of vestibulopathy. So these are, after that, I think I have short time left, so I'll come to vestibular habitation therapy. There are various types of physical therapies like Cawthon-Cook's exercises, which you all know. There are some yogic asanas, which are very helpful. And then there are something called a Tai Chi exercises, Japanese exercises, which are also very useful for selected patients of vestibulopathies, unilateral or bilateral. So what's new in vestibular habitation therapy? What are the advances? So nowadays, we are taking use of virtual reality or artificial intelligence for training of the patient. You can use biofeedback for rehabilitation, and there are protocols. There are very state-of-the-art protocols available for rehabilitation. Nowadays, you can do an organ-targeted vestibular pathology. The patient has got a right anterior canal and a posterior canal pathology, BPPV, then you can do a targeted vestibular physiotherapy using a chair. And these chairs some of the chairs are even manufactured in India, and some of our great gurus like Dr. Animar Viswas from Kolkata, they have designed their own chairs, because these chairs you buy from outside, from Europe, the cost goes into crores. Like this is one rotary chair which I had talked before. This rotary chair, you can give any position to the patient, and this is very helpful not only for diagnosis, but also for therapeutic or rehabilitative procedures. So this is new in vestibular habitation therapy. Now, because I have a couple of minutes left, let's have a sneak peek into the future. So what is the future of vertigo? So everybody has got a smartphone. We are all smart enough to have a mobile phone. So a diagnosis by sending the video of the nystagmus and the patient symptomatology, a remote diagnosis like telemedicine can be made, and therapies can be prescribed on the mobile phone. There are various apps available for therapies, and they are very beneficial. And even patients from rural areas who are very, I would say, mobile smart can use these apps for their benefit. There is something called a balance belt. This is especially useful for elderly patients who have got imbalance. And in these patients, the balance belt is applied to the waist. And whenever there is any change in the center of gravity, it gives alarms and signals and gives corrective directions to the patient. And so that prevents falls in elderly patients with vestibulopathy. And the last but not the least is the vestibular implant, which is not the future, but it is the present, because a lot of vestibular implants have been done worldwide with very encouraging results. It is very similar to a cochlear implant, but instead of the electrodes going into the cochlea, the electrodes go to the semicircular canals. And especially in patients who have got bilateral vestibulopathies or unilateral vestibulopathies with very poor compensation, vestibular implants are going to stay here, and they are going to make great difference to the patient. So this is a little bit sneak peek into the future. With that, I feel we begin with Alfred Hitchcock time. So vertigo for all of us here is like the story of the elephant and the blind man, and everybody has got a different perspective of the patient. With this lecture, if I am able to dispel this notion for even a very short time, I think my lecture will be worthy. So thank you very much for calling me and thinking worthy. Thanks again, the office bearers, the president, secretary, and office bearers of IMA Sangli, my dear friends there in Sangli, and all of you who have been patient enough to listen to my lecture.
Good afternoon, everyone. It indeed is a great opportunity to be available again and speak to the medical fraternity about the migraine and the management and the recent advances. Actually, migraine is the second most common cause of headache, and it indeed is the great cause for loss of man hours because of the disability it causes during the attacks of migraine. Prevalence of migraine gender-wise, the women are more preferred gender for the affection of migraine, and 18% of women do have migraine and 6% in men. If you look at the age prevalence, it usually is 10% in adult and 10% in children. The maximum, the age group which is affected, which affects migraine is from 25 to 55 years of age group. Many times, the people who refer to the headaches and report to an ENT surgeon than a neurologist or a physician, basically because sinus headache also is common, but usually migraine is misdiagnosed or not diagnosed at all. It's a clinical disorder characterized by periodic attacks of unilateral, throbbing and acute headaches, which may be preceded by visual, sensory or speech disturbances, and also accompanied by nausea and vomiting, which follow the attack of headache. There are two types of migraine. One is a classic migraine and the second one is common migraine. Both in classical and in common migraine attacks, there is a relative shortage of oxygen which manifests itself locally in the form of a hypoxic loci, which are called as cerebral hypoxia. In classic migraine, there is an initial vasoconstriction which is followed after some time, which has elapsed in a reactive vasodilatation. It is characterized by prodromal symptoms of aura. During the reactive vasodilation, there is throbbing headache. And as you know, the theories regarding the pathophysiology of migraine, you would have an explanation regarding why there is an aura and why there is a throbbing headache which follows. The common migraine, there's a likewise mention of which I did before, local hypoxia, which is caused by increased energy requirement under the influence of stress or effort, which leads to a reactive vasodilatation. However, in common migraine, there is no vasoconstriction and hence the prodromal symptoms or symptoms of aura which are not there. Migraine, it has got 4 phases, and the 4 phases have been divided into a phase of prodrome. Second one is aura, third is headache, and fourth one is postdrome, or that is phase of recovery. Coming to prodrome, this is the phase which is characterized by the non-specific symptoms like tiredness, yawning, mood disruptions, muscle pain, food cravings, especially for the sweet, and the cognitive disruption. Aura, which is seen only in 10% of the migraine sufferers. The symptoms may last for about an hour, which may start as temporary blind spots or zigzag lines in front of the eyes, or spots, blind spots in front of the eyes. There may be a blurred vision or sometimes flashing of lights in front of the eyes. Speech disturbances sometimes may accompany the aura symptoms which are already being mentioned. Sensations affecting other areas of the body such as tingling, dizziness, numbness, sensory loss, and limb weakness also may be part of aura. In the headache phase, there are various manifestations. the headache, which is the most prominent feature of this migraine. It may be throbbing, unilateral, aggravated by activity, and which may be moderate to severe in intensity. Typically, it starts in temporal region, goes to the vertex, and sometimes may get radiated to the occipital region. And it starts as a low ache, and then it becomes a throbbing headache. And at the peak of the headache, there might be vomiting, and then the slow recovery phase starts. It may be associated with photophobia, phonophobia, and many patients report about the photophobia and phonophobia. They would like to go to a quieter room without a light and would like to reduce their activities and remain quiet so that the headache does not bother them much. Patient prefer to lie down in darkened room until the attack ends. Nausea, which is reported by the half or more than half of the sufferers. Vomiting is seen in 20% of the sufferers, but it is indicative of particularly a very severe attack which has been there. Sometimes they may have a nasal congestion, rhinorrhea, lacrimation, and also sometimes diarrhea. The phase of recovery is with sometimes you have some lingering symptoms going on for some time. As the phase lasts, it may be even from 1 day to 3 days, that from 24 hours to 72 hours. The gastrointestinal symptoms may be a sick, uneasy feeling, a feeling of intolerance, decreased concentration, unable to perform the activities of daily living, may not be able to concentrate at workplace, maybe having, say, cognitive difficulties, sore muscles, especially the scalp muscles, which may be tender also on palpation, and overall sense of fatigue, almost like an post-epileptic attack, how the patient feels they may have a sense of fatigue. How the pain intensity worsens over a period of time, the activity is represented in this format. Prodrome for about 1 to 4 hours prior to the onset of the pain, aura which may last for up to about 60 minutes prior to or may merge with the onset of the pain. Typically, the headache lasts for 4 to 72 hours, and the postdrome symptoms which may last for a few hours or to few days. Okay. Prodrome which precedes by 24 hours, along with euphoria, irritability, sensation changes, local weakness, and physical symptoms. Aura may be visual, sensory, motor, vomiting, abnormal sensations, and resolves in 60 minutes. Then you have a phase of headache, as I mentioned earlier, unilateral throbbing associated with nausea, vomiting, photophobia, phonophobia, and lasts for 72 hours. And the postdrome after attack lasts for a few days, a few hours, exhaustion, extreme happiness, and sometimes few neurologic symptoms. There are many triggers which have been mentioned for migraine, and one of them, the most one, is the food. Many times it is called as Chinese restaurant headache. Most of the patients with migraine do have a sensitivity to the monosodium glutamate, which is most commonly used in all the Chinese foodstuffs. And the common word used for describing it is the Ajinomoto, which is part of the Chinese food. And many people will have a headache which is precipitated after eating in the Chinese restaurant. They may have disturbed sleep pattern few days before the onset of headache, hormonal changes, especially prior to the due date of the menstrual cycle. You may have precipitation of the attack of the migraine, drugs, physical exertion, visual stimuli Many times, people who work on the laptops or the PCs, the continuous flickering of the light in front of the eyes may be a stimulus for precipitation of an attack. Auditory stimuli, olfactory stimuli may also be part of the triggers. Weather changes, and then if people remain hungry for a longer period of times, the hypoglycemia sometimes may also lead to the attack of a migraine. Psychological factors also, depression is one of the commonest underlying factor of precipitation of such attacks.
Next.
Pathophysiology of migraine is still very unclear. Many theories have been proposed with regard to the main mechanisms involved in this clinical condition. It has been hypothesized that migraine could also be considered as a channelopathy. Genetic mutations lead to a defective sodium and calcium channels, which are linked to migraine. Widely used drugs for migraine prevention, inhibiting the function of one of the both ions, like calcium and sodium channels, also point towards the pathophysiology, which may be a channelopathy. And it has been proved that calcium channel blockers have been useful in the treatment, which also support the theory of this being a channelopathy. The vascular theory, which says that cortical spreading depression theory, CSD, and the neurovascular theory and the channelopathy. When we say that cortical spreading depression, which is an explanatory factor regarding the auditory, then visual aura which this patient gets before the onset of the action. Cortical spreading depression theory. Cortical spreading depression is a short-lasting wave of depolarization followed by prolonged neuronal depression. CSD is due to the dysfunction of calcium and potassium or sodium channels. This is probably genetic, and this starts from behind and travels forward at a rate of 2 to 3 millimeters per minute. These changes are associated with metabolic changes in nerve cells and reduction in regional blood flow. When you look at the trigger event like say stress, the cortical spreading depression would start. It would stimulate the trigeminal nerve. It will cause vasodilatation and pain, which is a manifestation of migraine. But if you look at this cortical spreading depression, which is at the surface cortex and leading to an aura. So the whole theory is explaining the cortical spreading depression as well as the vascular theory of migraine. Next. We'll not go to the details of this and come to the neurovascular theory. Migraine is also understood to be a neurovascular disorder. A stimulus triggers neural events in the cerebral cortex, which results in the dilatation of the meningeal and blood vessels and the release of the inflammatory neuropeptides, which stimulate the nerves around these blood vessels, which is called as neurogenic inflammation. And this nerve involvement sends an impulse through the trigeminal nerve into the trigeminal nucleus caudalis, and then it is relayed to the thalamus and eventually to the cortex. Coming to the neurovascular hypothesis, migraine triggers or CSD can activate the trigeminal nerve ends, which we saw just now, resulting into release of the neurotransmitters like substance P and neurokinin A. These neurotransmitters cause vasodilatation, extravasation of the plasma proteins and fluids, and this is called as sterile inflammatory response. According to this hypothesis, this vasodilatation and inflammation is an associated phenomenon of migraine and not of the cause of headache. Substance P and activation of nociceptors could be the cause of headache. And you know that substance P is a neurotransmitter for the transmission of the pain. Neurovascular theory, which we continue on. According to this hypothesis, trigeminal nerve is believed to be involved in genesis of migraine. Nociceptors are present at the nerve ends, and when activated, these nerves can release neurotransmitters. It results into release of neurotransmitters like substance P and neurokinin A, and they cause the extravasation of the plasma proteins and the fluids. As a second hypothesis of migraine, which is channelopathy, it involves sodium, calcium, ion channels. The abnormal activity of the sodium and calcium channels in cortical neurons leads to cortical hyperexcitability, cortical spreading depression, exciting the trigeminal neurons, leading to trigeminal neuron hyperexcitability, leading to peripheral and central sensitization. Coming to the clinical aspects of migraine, age and sex, migraine usually starts around the puberty, but on occasional case may commence as late as 40 years of age, and women suffer more frequently than men. But I would like to put a rider here that many times migraine may start at the age of 40, but you should never be able, you should not be labeling migraine around age of 40 unless you have done and ruled out other causes of headache, which are secondary ones. Coming to hereditary causes, it is extremely common for one of the parents of the migrainous patients to suffer from this disease. It should be borne in mind that both hereditary and environmental factors may account for this. Endocrine factors and allergy, there is a frequent association with migraine with puberty, menstruation, and menopause. As the frequency of the migraine reduces after the menopause, so definitely there is a relationship between the endocrinal factors. In some patients, allergy has been said to be precipitating migraine. Psychological factors, personality studies indicate that most migraine subjects suffer from insecurity and tensions, and sometimes patients with underlying depression do have frequent attacks of headache, which may be part of their migraine disorder. Coming to the diagnostic criteria for migraine, the occurrence of 5 or more lifetime headache attacks with similar features lasting for 4 to 72 hours each, and patients being symptom-free between the attacks.
This slide.
Okay, next one. Next. Okay. At the top of the slide, you see that there are simplified diagnostic criteria for migraine. This has been accepted from the Harrison's textbook of medicine, which is a commonly used textbook. At least 2 of the following features with an unilateral pain, which is throbbing in character, aggravated by movement, moderate to severe intensity, plus at least 1 of the following features like nausea, vomiting, photophobia, and phonophobia.
Slide.
Next. IHS criteria for diagnosis of migraine: moderate to severe pain, pain on one side of the head, throbbing or pulsating character, headaches exacerbated by routine activities, such as climbing stairs or climbing down. Then non-headache symptoms like aura, nausea, photophobia. The frequency vary from 1 to 50 attacks per year, average frequency 1 to 2 attacks per month, and the duration of each attack may be more than 4 hours to about 72 hours. Risk factors, age and sex, usually start in childhood or adolescent. Occasional case may commence at the age of 40. Women suffer more than men. Genetic migraine with aura seems to be more determined by genetic factors, while migraine without aura is determined by the combined and genetic and environmental factors. So the classic migraine is genetically transmitted, which actually indicates to us that neurovascular theory and cortical depression theory, which both could be at action in classic migraine. Endocrine factors, puberty, menstruation, and menopause, and the psychiatric factors like anxiety, depression, and bipolar disorders. Coming to the management of migraine patients, treatment during attack, and the preventive treatment. Acute abortive therapy, which can be used before or at the start of an attack, and the goal is to reduce pain, the duration of the attack, and which can be substantiated and used with analgesic, and sometimes there could be a reduction in the headache intensity, but there could be a rebound headache again. The preventive prophylactic therapy is used regularly to prevent attacks, and goal is to reduce the frequency of the attacks, disability, and improve the response to the acute therapy. Analgesics, simple analgesics like paracetamol or aspirin, and in the Western countries they use acetaminophen more commonly for the treatment of the acute attacks. Analgesic combinations can be used along with the diclofenac and other drugs which are tongue dissolving on the tongue, like mouth dissolving tablets which are available now can be used. Antiemetics, then triptans, more commonly used. There are many triptans which are available now, but the commonest being used is sumatriptan, which is available in the different formats. You can have it as a nasal spray, you can have it as an injectable, you can have it as a mouth dissolving tablet. Ergotamine I do not personally recommend, especially in elderly patients and who are predisposed to have the vascular disorders. The drugs which are used for the prophylaxis of migraine, calcium channel blockers like flunarizine and beta adrenergic blockers, propranolol. And this is the one which is very commonly used for the prophylaxis of migraine. Usually routine patients respond to the propranolol therapy. Then we have antidepressant, that is tricyclic antidepressants, more commonly used and also used in other headaches like cluster headaches, and that is amitriptyline is very, very commonly used for the prophylaxis of migraine. Anticonvulsants which can be used, and I personally use topiramate very regularly than sodium valproate and divalproate. Only thing we should be worried about in use of topiramate is that should not be used in children because it can cause loss of memory or learning disabilities sometimes, and in the people it may precipitate a closed angle glaucoma. Why prophylaxis? Abortive treatment do not prevent the occurrence of future attacks of migraine. Can result in medication overuse headache as they become lesser responsive in subsequent attacks. Prophylaxis improves quality of life by reducing frequency and severity of the attacks, and 80% of the migrainias may require prophylaxis. Migraine places a heavy economic burden on both the individual and the society. It is also known as migraine is a risk factor for the ischemic stroke in young women with migraine with aura. Recently, it was reported that some individuals with who experienced migraine with and without aura may be at an increased risk of subclinical lesions in the brain. Cerebral white matter lesions are a common finding in MRIs of these patients. Coming to the class of drugs useful in the management of migraine, I just skipped over the slides related to the Sibelium, which is I personally do not use more in our practice, except for the cyclical vomiting, which is almost similar presentation like migraine. The class of drugs are calcium channel blockers. In the past, verapamil was used for prophylaxis, not so commonly used now. Beta blockers, as I mentioned, the propranolol, it can be used in the dose of 40 milligrams 3 times a day, and you can use it in a sustained release preparation almost up to about 280 milligrams per day. Also, you need to monitor these patients' lipid profiles, because propranolol per se may cause alteration of the lipid profile. Then anti-epileptic drugs, which I have already mentioned. Here is a little, women have a lot of migraine, but you cannot use sodium valproate as a prophylaxis for them, because in a younger age group, they have a lot of side effects in women. So out of the anti-epileptic drugs, the sodium and valproate group is not available to us for the treatment of the patients, especially younger. I've already mentioned about this. We cannot be using propranolol, especially in patients with hypotension, bradycardia, heart block, and we all know that it can precipitate congestive cardiac failure. Plasma and cholesterol may increase. Alopecia, male impotence, GI upset. We cannot use propranolol in asthma and diabetes, because it may mask the signs of hypoglycemia in patients with diabetes. I have already mentioned about this. Okay, divalproate enhances the GABA action. By blocking sodium channels, this drug decreases excitability of neuronal cells. It is called as neuronal stabilization, and the dose which can be used about 800 to 1500 milligrams per day. The side effects: nausea, vomiting, liver toxicity, tremors, ataxia. Teratogenicity has been reported in women who are treated with sodium valproate during the pregnancy, especially the first trimester. So as a whole, sodium valproate is a good choice in men, but not in women in a younger age group who want to conceive and have children. Amitriptyline is one of the good drugs in the tricyclic antidepressant drugs. This inhibits reuptake of noradrenaline and 5-hydroxytryptamine. Doses from 10 milligrams to 25 milligrams at bedtime can go up to 150. I have used up to about 150 milligrams per day at bedtime. Side effects: dry mouth, epigastric distress, retention of urine, confusion, dizziness, cardiac arrhythmia, sometimes orthostatic hypotension, loss of libido, impotence. It is contraindicated in heart disease. Coming to topiramate in migraine prevention, it has been found that it has got a good result. I personally prefer it using in the younger generation patients and women. Eye testing needs to be done. Pressure, intraocular pressure needs to be monitored and done before we start the patient on topiramate. Target dose is about 100 milligrams per day. And
thank you, madam. Good evening, all. I am here just to express gratitude for this great and successful CME for all of us, with the stalwarts in their fields and faculties guiding us the whole day. Today's attendance was ranging from 320 to 350. Those who were on YouTube might be around say 50. So it was a great success because of the stalwarts who were the participants or giving lectures to us. I am thankful to Dr. Sharvil Gadave for his detailed guidance in type 2 diabetes mellitus. From our own medical college, guiding us regarding the adoption to telemedicine and technology for all of us in this COVID era, as well as after his lecture, I think many of us will dare to go for teleconsultations for with charges also, because his detailed guidance has encouraged us to shift towards telemedicine. I am thankful to young dynamic cardiologist, entrepreneur from our area, Dr. Ravikant Patil, for his valuable guidance. I am thankful to two Rushitulya personalities in neurology, respected Satish Khadilkar sir and Nathaniel Sase sir, for their detailed, valuable guidance in today's topics. Specifically, Dr. Satish Khadilkar's talk was really brainstorming for all of us who are running behind the money. Money is not all the thing. I was literally having tears in my eyes while I was listening to his lecture. Thank you, Khadilkar sir. I am thankful to both the ENT faculties, namely Dr. Ashok Purohit sir and Dr. Santosh Kulkarni sir, for giving us ideas regarding voice disorders and management and vertigo management, respectively, in a broader and detailed perspective. I am thankful to our Dr. Gitanjali Gupte madam, Dr. Pankaj Palange madam, for making this journey smooth from 10 a.m. to 4 p.m. till now. I am specially thankful to Dr. Sharad Ghadge sir for his observer's post via MMC. Though he is our past president, our own member, but I am specially thanking him for this responsibility. I am thankful to Johnson & Johnson and their team of representatives, Mr. Prasad and Mr. Bakre, for sponsoring this CME and having very good rapport between the speakers, IMA Sangli and DG Shield. All have worked hard. The team was working hard. As the time was coming and the pro forma was not getting set, the registration was not getting set, we have to become vigorous, and Mr. Bakre and Prasad has done all the things arranged for us. Thank you from bottom of heart from IMA Sangli. I am thankful to technical team of DG Shield for smooth conduction of this CME. I am thankful to our own Bapu Rajput for his valuable support. I am thankful to Maharashtra Medical Council for accreditation of CME, granting 2 credit hours with a short notice of time. But last and not least, you all attendees, without whom this cannot be a great success. I am thankful to all the attendees, registered and unregistered participants of this CME, making this a great success. My sincere thanks to Patwardhan Madam, President IMA Sangli, and Executive Committee of IMA Sangli for their constant support during the arrangements. Madam is much peculiar about the planning and execution of this CME. Regarding all programs, she is much strict and all. I am thankful for her valuable time for this CME. By mistake, if anyone has been missed out unknowingly, my sincere thanks to all of them, making us this CME a great success. Thank you all. I hand over the proceedings back to Madam and the team of Johnson & Johnson if they want to have a few words for all of us. Thank you.
Prasad sir, you can say something.
Yeah,
Thank you, sir. Thank you, Patwardhan madam. Thank you, sir. Joshi sir, given an opportunity for the Johnson & Johnson to conduct a virtual event. And as you know, Dr. J&J is always known in the science and the academic and the research. So I once again thanks all for giving this opportunity, and I also thanks for all the speakers also for the same. Thank you, sir. Over to madam.
I thank everybody from the bottom of my heart. It has been a wonderful CME, and it is wonderful to see all the people who have joined earlier in the day are all still there and glued to their laptops and watching and hearing this feast of CME, feast of these lectures. And I thank everybody. Suhas has already thanked everybody. I again thank all speakers, Mr. Prasad Sagar, Mr. Nilesh Bakre, digital team, everybody who has participated. My classmate, Dr. G.S. Kulkarni, who has introduced our two speakers today. And thank you all. Thank you one and all. And
just one minute I would like to take, ma'am. I specifically thanks my colleague at this platform, Nilesh. He has taken a lot of effort for right from the invite itself and the coordination with the DigiShield and for the links and the dry runs what he has been taken. So excellent job Nilesh has been done. And thanks DigiShield team also for helping us to execute this program in a successful way. Thanks once again. Yeah.
Dr. Abhijit, Dr. Gitanjali Gupte, Dr. Pankaj Palange, all have done a great job. Dr. G.S. Kulkarni has introduced the two speakers very well. So overall, we have a very satisfying end to this CME today.